It is a real, genuine honor and pleasure to be back in New Mexico. We lived here in Albuquerque from 1992 to 2002, and we only left because we had family calling us back to the East Coast. But every time I get to come back here, it's like my heart feels warm again. It is such a wonderful place to be. So I'm delighted to be back. This is kind of a summary of the work I've been doing for the last 13 years of my life. I started out as being a clinician, and actually I was at UNM, of all places, where I ran the education adolescent unit for 3.5 years. And then, and it's a long story, I was plucked from there to become the deputy clinical director of protective services for the state, and then eventually ran a community clinic for folks who couldn't afford treatment. And all of those were really wonderful, informative experiences. For a variety of different reasons, at some point, in 2009, basically, I lost the funding that I had because of the recession, and I ended up deciding to move over to the VA because, as a friend told me to move to the VA, I said, I work with children and adolescents and families. I can't do work with adults. And he said, no, Brian, you work with trauma. And he was really quite right, because that's what I do, and that's what the whole thrust of my clinical work has been over the years. And I have been talking all over the country about the issues of trauma in our criminal justice system, and I do it with judicial conferences, and I do it with attorneys, and I do it with anybody who works in treatment courts, and all sorts of different kinds of groups. I mean, wherever people invite me, I go. In a weird way, I hit it at the right moment when I started talking about trauma at what was formerly National Association of Drug Court Professionals, now known as All Rise conference. I was the only person talking about trauma there. And I'm sitting there going, wait. We're talking about substance abuse, and we're not talking about trauma? I mean, I was shocked like this. And I thought, have they read the literature? And so I somehow became known as the trauma because I happened to hit that slot first. And so now it is well known and well understood that, and as I will show you, that trauma is at the root of much of what happens in criminal justice. Much of what happens in criminal justice. And so that when we look at it, this is really the central piece. And what I'm going to do is try to take you through a variety of different ways, but basically understanding how trauma starts at the developmental and cultural levels, and then moves on through from there into everything from criminal justice to people being unhoused to the massive substance use problem we have in our country. So, I just want to be clear. You may notice that even though I worked for the VA, I couldn't put that on my first slide because we were just banned from doing that last week. Literally, things change all the time when you work for the federal government these days. And so we were told we could not say we worked in the VA, except that I could put the disclaimer saying that I'm not representing the VA. But okay. I don't have any conflicts of interest. This is copyrighted material, but you all will have a copy of it. I think Nancy is going to provide a copy of all this. It's very long. It's like 127 slides. So it's long. So you will have it. You can use it for your own purposes. For those of you who are working in courts, you're welcome to bring this material to the courts that you are working in. However, if you wish to present any of this material, I simply request that you email me to let me know, and then give me credit for what I'm doing. And the reason is that there are at least 4 times when my material has been presented by other people. And I've even had attorneys claimed my material and used it to advertise their business, which is really quite frightening. That's why that's there. So here's the question, why should you care about trauma? I mean, what's the point of it? And this is really basically why. So if we talk about adolescents in general, okay, we're not even talking about those involved in the criminal justice system. We're talking about adolescents in general. We've got more than 2/3 of them who have exposure to trauma in their lives. And 1/3 of them have polyvictimization. And as we found out earlier, exposure to trauma is a fact of life for delinquent youth. It's a fact of life. Why? Because it's 90% of them. 90. So here you see different studies have found slightly different things. The Abram study is the one that found the 93%. Another study by Ford and colleagues found 61%. More than half have 6 or more traumas. And I'm going to show you what trauma does to a person's brain and how they act afterwards. And 90% of them have multiple kinds of trauma who are involved in juvenile justice, and that's more recent. So, we're seeing the data converging at a very, very high level for youth who are involved in the criminal justice system. If you're looking at the adult population, the Substance Abuse Services and Mental Health Administration, who are the people who actually make these decisions, like how do you define the word trauma, they said back a decade ago that for people who have substance use and mental health problems, who are also involved in the criminal justice system, that then it is so high, the rate of trauma, as to be an almost universal experience. When I talk with judges, I say, when you have somebody walking in your door, and it's a criminal justice matter, you better expect that that person is traumatized, because the data say it's 87 to 93%, or 9 out of 10. If you don't expect it, and you don't expect what their behaviors are going to be as a result of that, then you're going to miss a huge, huge portion of what the story is. So, and here's a recent study that we had for veterans. 93% of incarcerated veterans have trauma. So, history of trauma. So you can see it's just everywhere. So this is the way I think about it. When people walk into, if you're a defense attorney, they walk into your office. If you are a judge, they're walking into your courtroom. Or if you are a district attorney and you're having to prosecute things, what they do to get in the court is the tip of the iceberg. It's only the tip. And the real story is what happened to them to get there. What happened to them? They weren't born this way. Okay? And so what happened? And 90% of the answer is true. 90%, which is an astonishing. So, trauma, what is it? I said Samson made the definition for it. And this is the definition that we call the definition. Some of you who were here yesterday have seen this slide and a couple of the other slides. The definition of it basically is something we call the definition of the 3 E's. So the first E is that you have to have an event. You can't have a trauma without having had an event, something that has happened. And you may think that that's a silly thing for me to say, but I work in the VA, and in the VA, you can get what is called a service-connected disability rating and be paid for developing PTSD from trauma. And so we have a lot of people who actually make false claims and claim that they've been traumatized. And because you can find these things on YouTube, there are training exercises, what to say to a clinician to make sure that you get your service-connected disability rating. And so they know all the symptoms and all the behaviors. They memorize it, they figure it all out. And then I'll ask them, So what was your trauma? What happened to you that resulted in this? Oh, mom and dad divorced. Or when I went overseas, my girlfriend broke up with me. Those things, while they are distressing, are not traumas. And we have come to use trauma as a word almost so lightly. You know, my boss yelled at me today, and therefore I was traumatized. Right? I mean, you hear these kinds of things. No, those aren't traumas. Traumas have to be, and this is key number 2, experienced as physically threatening, life-threatening, sexually assaulted. Those are traumas. And you might think about that as a capital T trauma. Okay, those are the things that I'm talking about when I talk about trauma, when Samson talks about trauma. And the thing is that you can have events that many people would consider to be traumatizing and aren't. If you think about the people who work as policemen and women, if you think about the people who work in emergency medical services, if you think about our soldiers and our Marines, they are all, and our clinicians, they are all exposed to trauma all the time. And yet we will say, oh yeah, well, it's part of my job. So it may not be experienced as harmful, although for some of us it is, and we develop something called secondary traumatization. But I talked about that yesterday when I talked, so I'm not going to talk about that very much today. Third part is, the third E, is it has to have lasting adverse effects. So you have to have certain kinds of symptoms, and I will talk about what those symptoms are, and certain kinds of behaviors that result. So, you know, if you ask about trauma, about 60% of people will say, and you define it like this, 60% of the people in this country will say they've experienced a trauma in their life. 60%. So that's pretty common. If you ask about post-traumatic stress, maybe too close. If you talk about post-traumatic stress, is that right? Then you're talking about, you're much more likely to find it, and twice as likely to find it in women as in men. 10% of women end up with PTSD, 5% of men end up with PTSD. Even though men are much more likely to experience the trauma, the post-traumatic stress disorder is much more likely to show up in women. And we could spend a lot of time talking about that, but the shortest version that I can give you is that if you look by the age of 18, by the age of 18, somewhere between a third and half of all women have experienced a sexual trauma. And of all the types of trauma that there are, aside from torture, sexual trauma is the most damaging trauma. And since more girls than boys it's about 16, 17%, then we end up, that's how we end up with much more post-traumatic stress for women than for men. So it has to have lasting effects and in different areas of personal function. There are a lot of types of trauma, and you know I've just listed a bunch of them. You know, there's a whole bunch of them that have to do with childhood, physical abuse, sexual abuse, domestic violence, overlaps childhood, and adulthood, school violence, which happens a lot these days, right? Then there's this whole set of traumas here that are intersecting with each other: cultural trauma, historical trauma, and intergenerational trauma. Intergenerational trauma is supposed to be there too. And those are all very potent, especially in certain communities. Certainly our Native American communities, we find that in Canada. If you're looking for reasons for why there's so much substance use, why we have that so much. But one of the reasons, one of the central reasons, is trauma. And then they have 3 different types of trauma as soon as they're born. as soon as they're born. That's what they're walking into. Environmental traumas can also be things like, you next to a volcano, or we have hurricanes, we have tornadoes, we have fires, more and more fires. Those are all environmental traumas, and so we have those kinds of things. We certainly have accidents. This is the most common type of trauma. How many of you have ever been in an accident before? Raise your hands. Yes. Ask that question around the country. And usually it's about 50%, and when I come here, it's like yesterday, it's more like this. And you can speculate yourself about that. Natural disasters, fires, forced displacements, torture, held hostage, combat in war zone, and genocide. There are this is only partial list. But there's so many different kinds of trauma a person can have. Post-traumatic stress, and I want to be clear, I want to distinguish that from post-traumatic stress disorder. I'm not a fan of the term disorder when it comes to post-traumatic stress, because actually these are things that happen to people, and that is not a disorder. It means it's a normal event. More than half of all people experience it. And so it is an unusual event, but it doesn't mean that there's something wrong with the person. I prefer post-traumatic stress injury or a post-traumatic stress response, and then to think about it as being on this kind of continuum where it can be anywhere from mild to moderate to severe. And in the moderate to severe range, that's where we start walking into post-traumatic stress disorder. There is no clear cut line. There are fundamental symptoms of post-traumatic stress because of the way the diagnosis and the clinicians. So they're the only one besides me. If you're a clinician and you look at these things, you got to go you got to go 2 out of this category, 1 out of this category, 2 out of this category, 1 out of this category, and there's 614 different ways to develop post-traumatic stress disorder combinations, which is kind of insane. So we have to start really at childhood trauma. That's what I want to see what it is. Every time a person is born, that's what's happening. But I don't like to stand in front of it. So childhood trauma. We have to start there. Why do we have to start there? Because it turns out that when we're looking at kids in June, how many of y'all are involved in juvenile justice groups? So a fair number. This is what we know. If you're looking at the onset of trauma for people who are involved in juvenile justice, basically between the ages of 0 and 1, a third of them have been traumatized already. Okay? Between 0 and 1. The grand majority of them have been traumatized by age 5 here. This is more than 2/3 of them have been traumatized by age 5. Okay, so what are we seeing? We are seeing people with very early traumas in their lives. At times, 0 to 1, they're pretty verbal. I have a grandchild who's 15 months old. She's just learning her words. I can't imagine anybody traumatized. I just can't imagine it. And yet, I've worked with these people my whole life. It's just incredible to think about that. And so, most of this is really happening into that 0 to 5 in terms of age of onset. So what happens in their brains is their brains start to change. And I will explain that to you and show that to you in a minute. 62% in the first 5 years of life. That's the actual. So if we look at childhood maltreatment, We're talking half to two-thirds say they have at least one traumatic event prior to 18, and severe sexual abuse numbers, again, prior to age 18, and it is also associated with, in other words, making people vulnerable to future adult victimization. I see this all the time because I work in the VA. What happens is we have people. There's only one spot I can stand for, and I'm not yet home. We have people, about 50% of men who come into the VA, who come into military service, and about 60% of women who come into military service have histories of trauma. Now, we spend a lot of time discussing why that might be. Are they coming into the military? However, if you look at people who experience military sexual trauma, almost all of them have been victimized in childhood. Almost all of them. And so it sets a whole lot of different things. It invades people's boundaries so they're used to boundary violations. It creates a sense that a person is bad, and therefore they deserve bad things to happen to them. It creates a kind of thing that predators know and understand. It is the predators of children and the predators of adults, sexual predators especially, have a special sense of who is vulnerable. And they are no different than the lion on the belt who says, that one's vulnerable, or that one is split off from the pack. And so it's not that they do anything that makes them more vulnerable. It's that the predator knows how to pick up who they are. And that makes them vulnerable. Here's more data on it. This is about the same. I think I quoted that data a minute ago. Domestic violence. So it turns out that between 10 and 20% of children witness domestic violence. And of course, when we say domestic violence, we can call it interpersonal violence. It is happening in the home. It's happening where the place that they're supposed to be safest is. That's what's happening. And so the way that constantly violates boundaries, I can't tell you how many people who I know who have tried to, as children, break up domestic violence and then become the victim of the violence themselves. There are an astonishing number of veterans who, in their teenage years, got so tired of the physical violence they and their mother experienced that they grabbed a gun on the predator and said, if you don't stop it right now, I'm going to pull the string. When I was working at UNM, one of my most interesting cases was a teenage boy. And the boy shot his mother's boyfriend, who was physically close, and killed him. And there was this really interesting question, because what they, and I'm not a forensic psychologist, I want to be clear about that, but the real question that was posed to us was the boy's story true? Because the boy said that he was St. George, and he was attacking a dragon. And the dragon was the man who was so. So you can see how the metaphor fits on time. So the question was he making this up or was he psychotic? And we did a lot of work with this story to figure out this whole thing. And we ultimately concluded that actually he was psychotic. He was psychotic because he was not just psychotic at the moment that he did it, he was psychotic at other moments too. And you can see how he might see himself as the white knight coming in to protect the maiden who was his mother. Well, trauma can do that to a person. Okay? When your brain is bathed in stress chemicals, which is what happens in trauma, it flips genetic switches. We all have these genetic vulnerabilities, some of it is heart attacks, some of it is diabetes, and some of it is alcohol problems, addiction, and some of it is mental illness. And in his case, it flipped his switch. I'm glad to say it did not go to his control. So it can be really powerful. So if you're a child, you are much more vulnerable to the experience of trauma because your brain is still developing. It is not developed fully. And I'll talk about that a little bit more in a minute, those exact things that's happening. But basically what happens is you are vulnerable. If you have a vulnerability, then you're more likely to experience something as post-traumatic stress than not. Sometimes those folks, the number is 30%. 30% of people who witness domestic violence themselves grow up to be abusers. The good news is 70% don't. That's good news. Post-traumatic stress in children and youth looks different, okay? It looks different than it does in adults. The nightmares, the things that they dream about tend to be monsters, as opposed to the adults who essentially live the events. It's a kind of repetitive play. I remember one of the kids that I worked with early in my career in play therapy. He would over and over and over again have an ambulance coming to his house. He was reenacting it in his play because an ambulance did come to his house because his mother was murdered by her boyfriend. And so that was the central thing. It was very hard for him. He was too young to talk about it. But he could play his way through it. There are also physical ailments that they have and other kinds of things. But I put this up here to say, diagnosing it in children, post-traumatic stress disorder in children looks very different than diagnosing it in adults. And this is what we find when they get to be teenagers. And this is how we get there. So what they end up having is mental health problems, substance use problems. Some of them become homeless. Some of them get involved in sex work. Some of them become violent. Some of them, and only some, end up in the child welfare system. Having worked in the child welfare system, I can tell you a whole lot of them don't. Sometimes we don't even find out about them so much later. And then involved in the justice system. And it's all because of the trauma that they experience. These are all common negative outcomes. And by the way, the more you have of one of these, the more likely you are to have the next one, and the next one, and the next one. So, trauma and the brain. I'm a psychologist. I like to talk about brains. Okay? Now you're going to actually see traumatized brains so that you understand. When I say a change in someone's brain, it really is a major change about what happens. So this is a slide that comes from a man named Bruce Perry. I was actually introduced to Bruce Perry when I lived in Mexico. I went to a conference that all the child welfare folks were invited to go to. We all went to this conference, so Bruce Perry came along, and he showed this slide. So it is a credit to him, not to me. And basically what he said is that he is really the world's leading expert on early childhood trauma, that 0 to 5 stage. And what he said is basically, if you look at this, you can have a traumatic event, and it changes your arousal system. So on the left side of this, you see an arousal system. And in this case, it happens to be calm to terror, but it could equally be calm to violence, because we have two kinds of arousal. And those two kinds of arousal are fight and flight. Violence is flight. Terror is flight. And so you can have an event, a traumatic event, and what it does is it jacks up the nervous system. And you move from something, and we love our big words in medicine. I apologize, I have to use the big words. But we move from what is called our parasympathetic nervous system, which you might call 0 to 50 on this scale, to our sympathetic nervous system, which is 51 to 100. When you are aroused with the trauma, you change physiologically. So I'm going to use an example that I used yesterday. But I'm going to ask people to just call out. How many of you first have been and walked up to the edge of the cliff at some point in your life? Most people. Why are we walking to the edge of the cliff? I'm trying to get this. It's like, I think it too, okay? Don't get me wrong. I'm not pointing fingers at anybody here. But why are we walking up to the edge of the cliff? So, let me call out something that they experienced when they were on the edge of the cliff. Is that? Adrenaline rush, absolutely. Someone else, another thing. Freeze. They got stuck, frozen. Oh, that was great. Another one. Panic. Yes. Flight. True. Let me out of here. Fear of falling. Fear of falling. And what happens to your bodies? Sweat. Yes. What else? Anxiousness. What else? Sorry? Your heart rate goes up. That's arousal. The body stuff is the arousal there that I'm talking about. And so what did you all do? Step away. And you don't just take like one step back, except for the person who's frozen. The person who's frozen isn't moving. Nobody said I wanted to jump. I have heard that answer. Those are the risk takers. But people usually take several steps. They take several steps. Why? Because they feel very close to the edge. You don't feel safe when you're one step backward. Why do we ever cross that one step? I don't know. What happens is there's a part of our brain, which I will show you in a minute, called the amygdala. And the amygdala is our threat response system in our brain. And what it does is it gives us 3 possibilities, except that we don't get to choose. And they are fight, flight, and freeze. Those are the 3. That's all you get. And you don't get to choose. And I'll show you why you don't get to choose. Okay? So what happens is this arousal system gets jacked way up when you're on the edge of the cliff. And what do? You walk back from the edge of the cliff. And then what happens after you walk back from the edge of the cliff? You settle down. And that's the way our alarm system is supposed to work. You get the arousal because it's about surviving, and then when you're out of danger, you settle down. The problem comes with how long it takes to settle down, and if you have another traumatic event. So this is one single trauma. And remember, I said to you, people we're working with, there's 6 or more. You go from here and you take this first one. This one is where you have something called dissociation, or you are what we call resilient. Resilience is great. We all wish we were resilient. It is not a trait. It is a set of behaviors. There are 6 of those behaviors which we can actually do to make us more able to bounce back. And if we practice those behaviors, then we can be better. But the other thing it says is dissociation. And that's interesting, because these are people whose arousal system comes back the fastest. And dissociation is this thing that happens where your mind leaves your body. And you're going to go, yeah, right. How does my mind leave my body? And dissociation is actually a spectrum. And here's the lighting. How many of you have ever gone into a room, please raise your hand. It's okay, you won't be alone, I promise. How many of you ever walked into a room and you can't remember what you walked into the room for? Raise your hand. Woo, look at that, right? You know, that's about 75% of the room. Yes, that makes you normal, okay? Okay. How many of you have ever done this? I've done this. Stick my hand in the refrigerator, and it's like my hand knows where it's supposed to go, and then my hand stops, and it's like I can't remember what it is. How many of you have ever had that one? Yeah, that's about a third. It's okay, you're normal. How many of you have ever driven down a long straight road, usually, and you're going pretty fast, and then about 30 to 60 minutes go by, and you kind of come back to yourself and you go, wait, I don't remember any of that. Why are you still alive? Raise your hands. Okay, woo! New Mexico is like, the norm is 33%, you know, about 50%. Unless it's happening a lot more here. I'm sorry to tell you, you're dissociated. Okay, so you think your mind can't read your body, you can't. And it will come back to you. And that's what it typically does, is your mind will come back to you. And it's now going to get into the dangerous range, which is when you do that and you end up somewhere where you don't know where you are. And people have that happen. I mean, I was working with a guy a few years ago, and he would dissociate, and he would call me after he woke up. Hi, I don't know where I am. Can you help me? Oh, what am I supposed to do? He said, okay, I want you to walk to the edge of the street, look for a street sign. And then I would get him to find 2 street signs, and then we would find where the intersection was to find out what part of town he was in. He was gone. So that's dissociation. The extreme end, and I mean the really extreme end, is, well, just before the extreme end you get to, something happens, you can't, you're gone for a while, and then you wake up a few hours later. I had a guy who came into suicidal, and I was called in to go see him, and he was suicidal because he couldn't remember the last 3 days of his life, 3 days of his life. And he was in complete panic about it all. And he thought she was crazy. But it's crazy. By the way, dissociation is not crazy. It is a survival response. It's a survival. And actually, it gets people better fast. Okay? And what we were able to figure out is the last thing that happened was he was in a bar. And that was not a good thing for him to be in a bar. And something happened at the bar which triggered a trauma response, and then 3 days disappeared. What panicked him, it was not the disappearance of those 3 days. It was that he woke up, and there were all these dishes in the sink, and there were things spread out everywhere, and there were clothes on the floor, and he had triple locked his door. And he was convinced that his apartment had been invaded. And he didn't know. And what we were able to figure out is actually he was dissociated for 3 days. Lived in his apartment. Didn't clean it up. Dissociation doesn't get to clean your apartment, so don't use it that way. It freaked him out completely. But once we were able to figure it out, we could calm down. We started working. We decided he was in great shape. But we have to deal with these kinds of events, okay? So when you have dissociation, it is a very successful survival mechanism because you don't remember the stress at all. You just don't. The next one of these, which shoots up the arousal level much, much higher, is you are a person who is normal and you have supports. Okay, so normal. How many of you all think you are normal? Raise your hand. Oh my God! You know, this goes. I asked this question around, and I have never had one or two answers. And then I came to myself just now, and it's like, okay. But for what it's worth, and I'm not going to ask you to raise your hands again, that is a minority of people in this room, and a significant minority, which suggests to me the possibility that if you're in this very small group, part of a large group, maybe the normal ones, the ones who are not normal, who think they're normal, aren't. You can see me at the break. I'll give you my rates. So we have tried as psychologists to define what normal is, and we tried it through the entire decade of the 1960s. We failed on it. We cannot define one's normal, so I can't really tell you. But whatever the normal thing is, and by the way, I've actually counted the number of normal people that I've met in my life, and it's 8. In my entire life, and I've been a psychologist for a long time. If you're normal and you have a support system, which is really important, yes, your arousal system goes way up, and it will come down relatively. That's a pretty steep fall. It comes down relatively quickly. If you are vulnerable, and I'm going to define that, and you have supports, then it takes a longer time. But the fact of having a support system helps a lot. And if you are vulnerable and you have few supports, you may not come down very much. So what does it mean to be vulnerable? Well, the first kind of vulnerability is that you have a prior history of trauma. And that's very common in most of the students. It's not just one singular event. They have a prior history. Another kind of vulnerability is that that people have difficulty putting their thoughts and emotions into words. They can't articulate it. They can't talk about it very well or clearly. That is a kind of vulnerability. Having few supports is obviously its own kind of vulnerability as well. If you have a mental health or a substance use problem, that is also a kind of vulnerability. It doesn't happen so much with kids, starts happening much more with teenagers. But that's what it looks like, okay? And I say this to say that this is a normal post-traumatic set of responses. Those are all normal responses. It's just that it just depends where you fall among these different things. So, traumatic stress and the brain. Start on the right side of this. When you experience something that you find to be traumatic, remember it has to be experienced as traumatic, your brain is flooded with stress hormones. A big word alert. It is, these are called corticosteroids. And the corticosteroids that flood your brain give it a bath. And then it changes your brain temporarily. And if you're lucky, and it's like walking up to the edge of a cliff, and you can walk back, and things get better pretty quickly, thank goodness. But that's not what it's like when you experience child abuse or child sexual trauma. And it's not what it's like with many and most adult traumas. This is not a quick event. It's a quick event to walk up to the edge of a cliff. It is not a quick event. Till your brain is bathed in these stress hormones. And when it is bathed in these stress hormones, 3 parts of the brain are affected. And the first one is here, it's this yellow one. It's called the amygdala. And the amygdala is an almond-shaped and almond-sized organ. It's actually 2 of them. You have them behind the bone that is behind your ear, the hard bone there, and into the middle of your brain. I'll show you where it is in a second. But they're in the middle of your brain, basically. It is an older part of your brain. It is part of that limbic system in your brain. And that's where the fight, flight, freeze stuff happens. That's where it is, exactly. And then if you work with veterans like I do, and you hear about what happens in combat, you hear that no matter how much bravado a person has, before they walk into a combat situation, they'll do one of those three. Some of them will run to the fight, the Marines have. Some of them will flee, they'll run backwards, and some of them will be frozen. Those are the three responses. Believe me, no person who's in the military ever chooses to freeze or run. And what the training that is given in basic training for veterans is to actually train them so that they have fewer freeze and flight responses and more fight responses. The problem becomes that when they come back, their conditions. But when they come back, they're not. We don't keep conditions. And actually, we have, and I'll talk about the special cases a little later, but actually, we have data that shows actually you can, which is really interesting. I'll come back. So the amygdala is like, okay, how many remember Space Family Robinson? All right, a few more today. Space Family Robinson had this wonderful robot, Robbie the robot. And Robbie the robot would always say, danger, danger, Will Robinson, danger, danger, Will Robinson. And he's the amygdala. That's what he is. He's the warning system. And then that's the amygdala going on. And it is attached here to a tube that is also part of the limbic system called the hippocampus. And the hippocampus basically mostly is the postal service for your memories. It also has something to do with regulating anxiety. That's why it but most of it is, it sends your memories somewhere. You had this event, go store it over there. And the problem is that if there's any sustaining part of the moment in which you're traumatized, the brain keeps putting out stress hormones, and this part actually shrinks. And we can see it in rats. We're not very nice to rats. Rats have the brains that are most similar to ours, that we are willing to experiment on. We don't do this to dogs. We don't do this to cats. But we seem to be willing to do it to rats. And so we can see in rat brains what actually happens. And they shrink by about 6%. And so you can think of it metaphorically as, this tube is ready to handle just so much, but the tube is only so wide. And if you get a big thing, a trauma, that the tube cannot digest, it cannot send it somewhere. And that is why we have one set of symptoms that we call re-experiencing. Those are nightmares. They are flashbacks. They are getting triggered by something which reminds them of their trauma. And so that isn't working. And then the third part of it is here in front, and it is in your prefrontal cortices. Don't ask me how you read prefrontal. I've never figured out if you read in front or front. There's so many weird things that we have. These are actually on the sides. And these are called the dorsolateral prefrontal cortices. And this part of your brain is the logical part of your brain. It's the one that thinks. It's the one that anticipates consequences of your behavior. It's the part of your brain that has any kind of reasoning in it. It's the part of your brain that does problem solving. It's the part of your brain that sees a risk. Uh-oh, I'm at the edge of a cliff, and says, step back. That's the logical part of your brain. And the problem is that if you're continuously flooded, and if you stayed on the edge of that cliff and still stood there for a while, this part of your brain would do as always. It shuts down. It just shuts down. Why? Because your brain is in survival mode. You're in survival brain. And that's what happens. You move from being a person who can operate in the world to a person who has three choices in the world, and they're not even your choices, and you just operate in survival. So, I think I just said, oh yeah, the other thing that the prefrontal cortex does is that it helps you make good decisions so you don't take risks. So therefore, it's really unsurprising that if the logical part of your brain is not working, that's what happens in post-traumatic stress disorder. It's permanent. Well, it's not permanent. You can fix it. But it is an ongoing condition that you have up until there's treatment. And in an ongoing condition, if people are not doing any of these things, do these look like the people you're seeing in criminal justice? That's what you see, right? And you're seeing it because the trauma has shut down the logical part of it. And so what happens then? Okay, so I'm just going to show you here that here's the amygdala down here, and there's an attachment up here to the hippocampus. And this whole part of the brain that you see here, this loop, that is what's called your limbic system. Now, we have really three parts of our brains, all of us have three parts of our brain. The first part of our brain to evolve is actually this part down here, it's the brainstem and the stuff over here. And that's the stuff that does things we do not spend our time being conscious of. Like, for example, your heart beats, but we don't tell our heart to beat. Or you breathe. We don't tell ourselves to breathe unless we're meditating, slower. But that all is the automatic stuff, part of the brain. And that is all there, 100% of it as soon as the baby. It's all there. The limbic system is about 50% built at the point of birth. And it continues to be developed until somewhere between the ages of 3 and 5. Now remember when I told you that children are most likely to get harmed between the ages of, first of all, 0 and 1, and then most of it by 3 to 5. This limbic system that we have has two functions that are really important. And one function of it is to facilitate attachment behavior. To facilitate attachment. I think about, looking at my 15-month-old granddaughter. The last time I walked into their home, she doesn't walk yet. She has a little trouble walking. But she walks on her knees. And she started screaming and walking on her knees over to me. And she was so excited. And I want to tell you, that was the best thing in the world. You ever want to have happiness in your life? Go get yourself some grandchildren. I'm really serious. Wow. I have kids first, and that's an interesting problem. Get yourself grandchildren. It's the best thing in life. But talk about facilitating attachment. It's like, oh, what does that make me feel? My daughter was really upset, and she says she doesn't react like that when she sees me coming home during the day. So she was really upset, and I'm sitting there going, this is attachment behavior. And it makes all of those, we have a hormone called oxytocin, and it is the part of our brain that just feels warm and lovely. We really love, and that's when oxytocin is there. And if you ever want to have oxytocin in your life, smile. Smile. I'm really serious about this. Smiling releases oxytocin. It really turns out that that's true. You know who has the most oxytocin in life? It's the Dalai Lama. You ever seen pictures of the Dalai Lama? He's always smiling. He's always smiling. Yes, I'm teaching you about your brains as we're doing this. Okay, I understand that. That's very intentional. So, other thing that this does is that the limit system here is what allows us to do emotion regulation. So our emotions get too high, our arousal system gets too high, we contain it. Okay, now, how many of you have ever wanted to punch somebody in the face? Raise your hand. How many of you actually did punch that person in the face? I'm getting really worried about this group. Oh my goodness. Most of us will have the impulse to punch somebody in the face at some point in our life, and we'll actually restrain ourselves from that particular impulse. We'll not do it. That's emotion regulation. There are times where we may want to get the heck out of wherever we are. Your boss is yelling at you, and it's like, I don't want to get out of this office. Do I walk out of the office? No, probably not, because I don't think my own boss would think a whole lot of me. So I learned to do what Dalai Lama does and give a half smile when he's a different boss than the one I have now. But I had a boss who liked to yell at me, and I learned just to do the half smile while he yelled at me. And that confused the heck out of me. He didn't know what to do with that, and I felt fine. I'm actually trying to teach you some things that you can use in your life, okay, folks? So the problem is that you can't be attached to other people because limit system and all that stuff. And if you can't, your emotions get dysregulated and therefore lead to more extreme forms of behavior. Do we have a label that we might call that person? The clinician in the back knows the answer. Oh, okay. So the question is, when you have somebody who is emotionally dysregulated and they have significant difficulty attaching to other people, and it may include that they do get over-attached initially and then they blow up the relationship and destroy it, what do we call that kind of person? Reactive. So in a child, we call them somebody who has a reactive attachment disorder. And then they magically hit the age of 18 and suddenly they have a borderline personality disorder. That's what we call them. And we see them all over our justice system. All over. You know the other group we see all over our justice system? Antisocial personality disorder. And those people are often emotionally dysregulated around their rage, and they rarely have more than one relationship. Rarely. They're the same kind of thing. Why? Because these are the people who had this happen between the ages of 0 and 5. Between the ages of 0 and 5. So there are all sorts of things that happen. This is the stuff that happens when you have too much corticosteroids, and your amygdala is going off all the time. The same danger, Will Robinson. Chronic fear and anxiety, inattention, overreactivity, impulsivity, hyper-alertness, and sleep problems. Can anybody give a diagnosis to that? Works in juvenile justice? Or education? ADD. Boom! And you know what we do with those kids? We give them stimulants. I cannot think of a stupider idea than to take somebody who is hyper-aroused from trauma and giving them a stimulant. That is really dumb. And by the way, there are 4 studies that show that kids who are like this and have something called complex PTSD, which I will get to, get misdiagnosed with ADHD all the time. All the time. And we literally mistreat them. Oh, and then they become teenagers and they're still taking stimulant medication. Now, what do you think happens to teenagers who take stimulant medication, which is, by the way, addictive? What do you think happens to them? They start using other substances. And you take kids with ADHD, they're the ones who are most likely to drink. They're the ones who are most likely to use cigarettes. They're the ones who are most likely to start at an earlier age to use other substances, which are very, very dangerous. And now they're starting earlier and earlier to use cannabis because heck, you can get it on almost every street corner. I mean, I was driving around yesterday and been here in a couple of years. I like to visit my old ponds, go to the museums for lunch, and I counted, and I could not go 3 blocks anywhere in the northern part of the city without seeing a cannabis shop. 3 blocks. $5 joints, literally. That was the name of it. So here's another kind of thing. These are different stress steroids. But here are people who have distorted attachments to other people. They tend to be disengaged. They numb. They have a hard time feeling any empathy or remorse for another human being. I might add, there's also violence that goes in there. What do we call that person? Sociopath, antisocial personality disorder. Sometimes we call them psychopaths. Okay? And I will tell you that the data say that 74% of those, 81% of people who have borderline personality disorder have this in their background. 74% of people with antisocial personality disorder have it in their backgrounds. Why is it smaller for those people? And I believe that the answer is this. There are about 10 to 15% of people who are sociopathic who have deficits, and the deficits are, number one, they are unable to feel pain. You know, you can stick a needle in them, and we do needle tests. You can stick a needle in them, they don't feel any pain. And the other thing is they don't have something that we call mirror neurons. And mirror neurons, which make about 10 to 20% of the brain in certain areas, are what allow us to copy the behavior of others. They're what allow us to feel the feelings of others, which is what we call empathy. Empathy. And so what happens to them is they don't feel any pain. They don't feel other people's pains. Well, then they can put themselves into other people's shoes. There's no remorse. Nothing. Because pain doesn't exist for them. That's about 10 to 15% of the people in this category. And you have to do electrical testing of their nerves. Although sometimes you can say, just ask them, you ever feel pain? Like, you know, if you cut yourself, do you feel pain? And it's a simple question to ask. And they'll say no. Why 10 to 15%? They are different. They are miswired. And then because of all of this, they can also start having cognitive impairments, emotional dysregulation, etc. And then you have changes, structural changes, functional changes. You see the brainwaves actually change in these people because they're aroused. They don't have the calm brainwaves, the theta waves. They have lots of delta waves. Guess what's happening? If you trauma exposure, those 3 things that I talked about, the amygdala, the hippocampus, and the prefrontal cortex, yep, they're all shrinking. All of them are shrinking. That's not a good thing. And the earlier you get it, and the more it happens, the worse the changes are. So this is what happens in a child's brain. There is this first part, which is the brain stem that I mentioned. That develops first, and that happens in utero. Second, you have this limbic layer of the brain, which I just described to you. And as I said, some of it is in utero, about half of it, and some of it is in the first 5 years of life. And then this part is the cortical brain for the thinking and learning part of the brain. And that's just another picture of the brain. So here are what real brain is. Okay? On the left-hand side, you see a person, a child, and this is a matched comparison, 2 11-year-old boys. And you have to look a little bit closely, but if you know what to look for, what you start looking for is what's the overall size of the brain. Look how much more cortical brain this one has than this one has. Or if you're looking at size of holes in the brain, we all have holes in our brain, don't worry about it, although if you have substance abuse, especially meth, which is giant. Look at the holes, many more holes that are in the brain, in the deepest part of the brain. Another thing you can look at is the folds in the brain. On the left side person has a lot of folds. The right side person does not have many folds. That's cortical activity over time. You see more folds you see in the brain, basically the smarter that person is. I mean, this is correlated with my brain. More folds in the brain. So what you're seeing is, yeah, if you have a history of trauma, it's very different from brain to brain. So here's, and this is a lovely thing that was done by the Ohio Department of Education. And they did it to basically show that in quote-unquote typical child, there's part of the brain that is survival brain. We all still have it. We need it, just in case. And here's the second thing that happens, and that's about the emotional regulation, the behavioral regulation. The third area is social emotional, which is relationships. And the final area is cognition. And in a normal brain, more of the brain activity is taken up in cognition and in relationships than emotion regulation and survival. But in an abused child, it's exactly the opposite. Exactly the opposite. So guess what happens if you don't get along with other kids so much? Because your brain capacity does not allow you to. You're in survival brain. Or guess what happens when there's not a whole lot of energy that you can put into thinking, because after all, that part of your brain is smaller. Anybody got any? What happens to that job? They fall behind in school. What else? Same in court. Same in court. Yes. That's sort of the next step. This is where you see learning disabilities coming out. And you get more learning disabilities in kids who have been traumatized. They really don't do as well in school because the social emotional stuff that happens. They're more, and they can't regulate their emotions and behaviors as well. They're going to get into more fights. When they get into more fights, who's going to be their friend? The other kids who get in trouble. And we know that the single best predictor from research of adolescent delinquent behavior is who you hang out with. It's not anything else. It's who you hang out with. They've been damaged in their ability to hang out with other kids. And so that is what happens typically. And the point is that when you're a traumatized child, your brain has shifted from focusing on learning and education and thinking and planning to focusing on survival. The right side is the survival. The left side is cognition. And now we come to adults. Some of you are probably wondering, is it ever going to get to adults? Now we're coming to adults. These are pictures of two real brains. I'm really spending time on this because I really want you to understand how brains are really, truly different. Here is a healthy brain, which means that they did not have exposure to PTSD. Okay, this one also doesn't have a history of traumatic brain injury, and that can happen in kids a lot. I had a daughter who was an ice skater, and she banged her head 3 times. So this is seen. These brains are being pictured as if the camera's up here. It's from the top down. Okay? And this is the front of the brain here at the bottom, and that's the back of the brain up here. And this pinkish, orangish, I can't even describe that color, stuff is dyed blood. So what they did is they dyed the blood. And wanted to see where did the blood go. Why? Because the part of the brain that is active is where the blood goes. Pretty straightforward. These are the dorsolateral prefrontal cortices. right behind the forehead, and that's where most of the blood is. You may have to look closely, but those of you can't see all the way up there can look at the bigger ones that are in the back. There are also 2 dots here, small, and 2 larger dots there. And I want you to notice that, because I'm going to show you something later in this presentation that is fascinating about treatment. So here's where the blood is. And now we go to the PTSD, the brain of somebody who actually has been diagnosed with PTSD. And the blood is everywhere. It's all over the place. And I've showed this picture to many of them. Many of my patients have seen this picture. And I will do what I'm about to do with you, with them. And I will say, well, you see this big area here, sort of, it's towards the front and center here, and that's got all this activity that is going on there. Well, that part of the brain is the attentional center in your brain. The attentional center is what makes you pay attention. Why is that lit up? It's lit up because if you're post-traumatic stress, one of your symptoms is you are what is called hypervigilant. You look for danger everywhere. I mean, if you were a person who had PTSD, you would not sit in this front row or the middle row or the next row. You would be around the edge of the room somewhere, probably a man with a cup of coffee in the back. Would you mind? I'm not saying this is true. I promise. But you would stand there. Now, you might stand where this guy over here is, although I'm not sure entirely, because you have to go around the corner a little bit. Why would a person stand there? To observe the entire room, to be able to see everybody and what they're doing. You can scan for threats. What's the other reason? Run. That is the fastest way out. Boom. And so if you were a person with PTSD, and I'm not saying you are, I want to be really clear about that, that's where you would be. That's where you would be. And if she got there first, you might go over with this. That's why this is so lit up. Okay? It's all that attention. Scan that room. Talk to my veterans about you. What are you scanning the room for? Every time they come in, every time I meet a veteran for the first time, I've learned many things to do. And one of the things that I do is I walk in front of them. Why are you walking behind me? Believe me, because they have eyes in the back of their heads. Police officers, POs, your POs. POs. So this is all lit up. Now, these parts of the brain here and here, about in the middle, on the edges, those are your hearing centers. Why are those lit up? Because part of the vigilance is to sound. You always want to be able to respond to sound. People with PTSD often wake up in the middle of the night and they'll say, I heard a sound. And they'll wake up and they'll go and check all their doors and windows. And they'd already locked them. And they may have gotten up 2 or 3 times before that and made sure that they were locked. And they still believe that somebody was there. And I always teach them a simple rule. Most of them have dogs. And I say, do you believe your dog? And they say, what do you mean, dog? And I say, well, does your dog bark when somebody comes to the door? I'm staying with friends, they have 2 dogs. I come to the door, there's dogs, they're barking away. That's what they're supposed to do. And I said, does your dog bark in the middle of the night? Well, if there's something there, I said, exactly. And are you listening to the dog? And they say, what? And I say, well, are you going to check your doors and windows after you've already checked them? Yeah. Is your dog barking? No. You need to believe your dog. Trust your dog. Now, these parts here on each side, yeah, those are the amygdala. There they are, they're lit up. firing away if the person has PTSD. These parts up here at the very top, that's actually, this is back here. They are the visual centers in your brain. It's where you actually see, because your eye does not see. Your eye really doesn't see. Your eye's a camera. But translating what the message is different, because you have lenses, and your lenses turn you upside down. And it has to be flipped back right side up, somewhere in your brain. Otherwise, you think you'd be upside down. You're swimming right now. That's what's lit up there. So why is that? Same thing. Scanning the room, got to see. Then you get this. You get this thing down the middle, and it's pretty long. That's the motor cortex, and that's the part of your motor cortex that has to do with your legs. They're long. Why are your legs lit up? Because you're going to run or you're going to kick. That's why your legs are lit up. They are ready for action, which is why arousal hormones really good. Let people feel on edge all of the time when they have PTSD. And this part here, right in the center, those are your fists and your hands. You have a lot of blood that goes to the hands. And again, here it is in this fight. This fight. That is a survival brain. That is what survival brain actually looks like. And I have seen actually many brain scans of the people that I work with. And since everybody I work with has post-traumatic stress or claims to it, that's what it is. The brain has changed. And so the question I always ask my patients, I say, now there should be a question in your brain at this moment, now that I've shown you that. And most of them can tell me the question that I'm hinting at. And that is, how do you flip it back? That's important too. Trauma doesn't just live in the brain, it lives in the mind, because we have these beliefs about things, and it lives in our bodies. And if any of you are familiar with ACEs, which I'm going to talk about in a moment, you know what I mean by it lives in the body. There's a famous book by Bessel van der Kolk called The Body Keeps the Score. It became a bestseller during COVID. I don't know why. It was a book for people like me who are psychologists and therapists, and I don't know how people can go through all of the mundane detail that is in that book unless they are fascinated by trauma. There is a phenomenon that happens, and it is called weathering. There's a book that came out from a woman named Arlene Geronimus a couple of years ago. And if you're really a nerd about this stuff, it's a great book. Otherwise, it is stultifyingly boring, I can tell you. And what she shows all of these different things. But one of the things that she focused on are called telomeres. And I recommend that you look to a screen that's close to you because it's a little hard to see. Telomeres are the yellow parts at the tops and bottoms of every single chromosome that you have. Every one of them has it. And when you're a baby, that's when telomeres are at the maximum. Because what telomeres tell the cells to do is reproduce. And the longer your telomeres are, the longer your cells will reproduce, and the longer you will live. Well, that's good news. However, as you age, your telomeres start to get shorter. You don't reproduce as many cells. My father was 5'11" when I was a teenager. My father came to live with us in the last decade of his life. And he was 5'6" by the time he died. He was shorter. I got worried recently because I got my height measured. I've lost an inch and a half. You know, when you get older, you lose these things. Uh-oh. That's scary. You get older. And at the point when you basically evaporated your telomere, your cells don't reproduce anymore, and you die. That's what happens. Okay? One sign of death. Here's the problem. Corticosteroids attack Tell me. So you know what happened? Early disease, early disability, early death. If you have chronic stress in your life, and it turns out that it's either trauma or poverty that does this. That's what we figured out before reason. Trauma or chronic poverty basically will make those things happen. So we say that post-traumatic stress disorder is a normal response to an abnormal event, which is a trauma. So what is post-traumatic stress disorder? Well, I've been talking about it this whole time, okay? And I'm not going to spend lots of time talking about other than what I said. Here are our categories. So you have to have exposure, the first E, to an event. And something has to happen. And then 4 other things have to happen as a result. The first one is re-experience. These are nightmares, these are flashbacks, these are images you can't get out of your brain. When I was here, when I lived here, I was an expert witness in a case. And it was a really, truly horrible case of child abuse. And I won't tell you the details because I do not wish to trigger anybody, because triggering is a part of re-experience. And I'm not going to trigger anyone. But there were pictures there. They were some of the most horrible things I've ever seen in my life. I can still see those pictures today. It's been 30 years since I saw those pictures. Why? Because in a traumatic event, remember that the hippocampus, which is required for any memory to be sent somewhere, to stay there unless voluntarily called for, has shrunk. And so it can intrude. Now, those pictures don't intrude on me anymore, but I can still call them up. I can't unsee those pictures. And they weren't the only pictures I saw when I went to see what I did that day. And triggering happens. And triggering, I don't mean triggering in the sense as I was triggered because my boss yelled at me today. That's not being triggered. It's like, yeah, it was upsetting, it was distressing that my boss yelled at me today. Triggering is actually bringing something from the past back into the present. So that's repetitive re-experiencing. Avoidance of stimuli associated with the trauma. So basically, all sorts of things can be avoidance. Sometimes it's flight. Sometimes it's numbing out. But mostly, it's people will stay away from certain things, anything that reminds them of the trauma. I had a gun pulled on me when I was 21 years old, and supposedly trying to keep a friend of mine safe from any bad thing that could happen, and I was escorting her home on the Boston subway, and the gun was pulled on me and shoved into my chest, and they said, "Give me all the money or I'll blow you away." And so what happens, at that moment, you can have re-experiencing of it, so that and avoidance of it. I did not avoid it because I was trained early on as a child to witness all this, everything. And because that was about my father's trauma. She, after this episode, could not remember anything. She dissociated. That's avoidance. And within 2 months, she had flown to the other side of the country to live, and she never spoke with me or other friends again. That's avoidance in extreme trauma. Substance use is also a form of avoidance. You can avoid by having a special room in your home. Veterans will have special rooms in their home, their man caves or their she sheds, and that room is the only place that they feel safe. Then there's negative moods and thoughts. The negative moods are the following. They are anger, they are fear and anxiety, they are guilt and shame and depression. Those are the ones you get. Those are the negative moods. The negative thoughts are things like, I'm a bad person, I don't deserve good things in my life, I'm evil, The world is a dangerous place. I am not safe anywhere I go. I mean, I could go on, but these are the negative thoughts that people have. And then there's the increased arousal, and we talk a lot about arousal, but in this category, specifically speaking, we are talking about everything from anger and irritability on from there to talk about people can't sleep because their arousal system is up. And then they get stimulants from the kids, and they really can't sleep. And also, they're very jumpy. You start very quickly. And all of these are signs of increased arousal. That's how you get PTSD. I think I've said this. Yes, I've already said that one. I'll skip that. It is important to say that not all trauma leads to PTSD. Somewhere between 3 and 58% get PTSD, with the exception of torture, in which case it's close to 100%. Close to 100%. So these are what I think of as the trauma tree. Here's the trauma. The trauma is the soil in which the tree grows. And, or if you want to think of it, it's the roots of the tree, is another way to think about it. And these are the versions of it, something called acute stress disorder, which only lasts for up to 30 days. You may have something called adjustment disorders, which may last longer than that, but they're not very severe, so they're low on the severity end. The next kind of thing they may have is a junk pile called other trauma and stress-related disorders, which means they have so many different symptoms, but none of them meet the criteria. You can have PTSD. You can, oh yeah, I'll get to the other parts. So what does it do when we see juvenile justice? And just here are some of the things that are notable. 40% of them or so are involved in the child welfare system, who are also in the juvenile justice system. That should give us some alarm. 30% of incarcerated youth have PTSD. 70% of justice involvement youth have at least a mental health disorder. 79% of the 70% have 2 or more mental health disorders. In other words, that's about 50% overall. And these things, PTSD symptoms, PTSD thoughts, that's the difference between being exposed to violence and being ended up with being called a juvenile delinquent. And also there is something called complex trauma, which leads to higher aggression and more juvenile justice involvement. Now I get to the substance use stuff. Well, this is the avoidance, right? So we're talking about the avoidance here. And basically what we find is more traumatization leads to more depression, PTSD, alcohol, drug abuse. If you're poly-victimized, which means you have more kinds of or more perpetrators, you get more of that kind of stuff. And here we are, 79%. So we're talking 4 out of 5 youth who are arrested because of a drug-related offense. But are we looking at them to see if they have histories of trauma in our juvenile justice system? And I can tell you we're not. And then I don't know how we're going to treat them. Because we don't treat the trauma, the substance abuse, it's going to continue. And the violence is going to continue. There are a lot of studies that basically show that there's domestic violence. You end up with a lot of other problems. One of the most notable ones is suicidality. PTSD has lots of ways of getting to where violence is. Okay? So it's that irritability, the startle response, the anger, the aggression, all of them are symptoms of PTSD. You can get the violence because if somebody is isolated and alone and you tap them on the shoulder, suddenly you get an outburst. Or they respond quickly to sudden movements. I had a guy who was a Vietnam veteran, and he was driving his grocery cart in the grocery store. It's a normal thing, right? And he did it at a time of day, which was very early in the morning, because he didn't want a lot of people there, because he was avoiding. And this guy gets in front of him with the cart. And he just stops his cart in front of him. And he bangs his cart against my patient's car. And you know what my patient did? He had a cane. He was a Marine. He stuck on a cane. Suddenly they realized, and he collapsed. It's out. That guy was right. He interpreted the guy's threat. That's what happens in these kinds of moments. Now, the police, fortunately, there were people who saw this and said, oh no, this other guy was provoking him. And so he did not get arrested. He could have been arrested for that. The guy had to go to an urgent care center to check out whether there was any damage to his throat. The guy could have sued him, wouldn't have worked probably. It was a provocation. You can't do those things to people that PTSD, but unless you know how to spot them, you won't know who they are. Flashbacks, dissociations, people do attack their partners during nightmares. And when they're reliving something. My advice to them is always the same thing. I always tell them, always have a set of pillows by your bedside. And after you have your intimacy, stick that set of pillows in between the two. Because it's very hard to punch through or over a pillow. Punch over a pillow, it immediately stops, and then you can sleep. Here is where we see PTSD and our legal system. Domestic violence, child abuse, divorce, malignant state, non-housed, DUIs, DWIs, misdemeanors, threats, violence, criminal behavior. It's everywhere. It's just everywhere. How do we know about this? And we're talking about men in this case. 25 to 68% of them have physical or sexual abuse, which are only 2 of 17 different kinds of trauma. The estimates seem to be somewhere between 1 in 5 and about half. If we talk about men and women, you also get childhood victimization, more physical assault. Women, for men, more sexual assault for women. And this is how the IOM concludes this. If you have PTSD, how do you get to legal problems and incarceration? And the IOM looked at thousands of studies. And basically, this is what they said. If you have anger and aggression, fight. If you have alcohol abuse or drug abuse, fly. That's how you get. The people with PTSD are much more likely to get to legal problems and to become incarcerated. Trauma leads to lots of other kinds of problems. We do know that 60% of people with substance use disorders have experienced trauma. We just know that there is a lot more. Rates of child maltreatment are very high amongst drug users. 55 to 99%. Yikes. Rape victims, child abuse. And I'm going to take a moment. We're going to take 10 minutes here because attention spans drop at about 90 minutes. Walt Disney proved this. Please take 10 minutes. In 2002, when I first started talking about this, nobody had any idea what I was talking about. Basically, it is a study that came out of a health system called Kaiser Permanente, 17,000 plus adult patients. And it came out of an obesity program. The short version of it is that they were able to help people lose weight, and they were very successful. And then when they were off the program and they did follow-up, almost everybody bounced back. And so they decided to do a follow-up study and say, well, why did you bounce back? What happened? And they started hearing these stories. They heard the story of a woman who said, well, I was sexually abused as a child. And I learned that I did not want to be attracted to men. And if I gained a lot of weight, men would not ask me for a date. And so I gained weight. And when I started losing weight again, I started getting asked out for dates. And it freaked me out. And so I started eating it. They talked to a prison guard. And the prison guard asked him what was going on. He said, well, when I was a kid, I was really bullied. And I was beaten up by a lot of people. And then when I became a teenager, I became a big guy, and I was a lineman on the football team, and nobody messed with me. And now I'm a prison guard. And when I was big, before I started losing weight, nobody would mess with me. Nobody would make fun of me. Nobody would spit on me. Nobody would urinate on me. And he said, when I lost weight, as part of this program, people started doing all of those things. And they realized they were onto something. And the short version of it is to tell you what they were on to. They ended up coming up with 10 categories of events that happened. 5 of them have to do with physical abuse, sexual abuse, and emotional abuse, physical and emotional neglect. So abuse and neglect. The other 5 were conditions in the home: mental illness, having a relative who was incarcerated, divorce of the parents, domestic violence against the mother, and substance use. Okay? And so they looked at all of these things and what happened as a result. And they developed something that was called a dose-response curve, is what they saw. And the dose-response curve basically means that the more of these ACE events you have, the worse your life is. The worse your life is. And most of what they looked at was health consequences, which is very interesting. This is very much related to the telomere stuff that I showed you. And a lot of it also ended up being about certain kinds of behavioral health. So here are ACEs scores, and here are what are their chances that they abuse drugs. And you can see if there are no ACEs and 1 ACE. And by the way, 60% of the American public has 1 ACE. You probably have an ACE, and that's okay. But as you get up to 4 or more, things start looking a whole heck of a lot worse. When they looked at suicide attempts, the same thing happened. It was pretty low. 3 got higher. 4 or more ACEs, that's where people were trying to kill themselves a lot. So there were a lot of these things that happened. So they found that there was much more in the way of health problems. And the health problems that they had were really health problems that could be choice problems, like drinking or smoking cigarettes or things like that. And so you see smoking, IV drug abuse, depression, attempted suicide, alcoholism, and especially those 4 or more people. I want to ask Vince Belletti. This was done by 2 guys, Belletti and Anda. And I knew something new, and they gave me his phone number, and I called him up and said, why isn't PTSD on this list? And he said, I'm a primary care doctor. I'm not interested in PTSD. Okay. This is the ACEs pyramid. Okay? And this is conception, that's death. And it starts with adverse childhood experiences, which we've been talking about. And then they get disruptive neurodevelopment. And I showed you how it changes the brain and how it changes the telomeres and how all that happens. And then you start getting social, emotional, and cognitive impairment. And that's what's happening in childhood during the school age years. And then in the teenage years, they adopt health risk behaviors, smoking, drinking, drug abuse, etc. And then as they get older, disease, disability, and social problems. And the magic number was around 50 to 55. Suddenly they started seeing people with disabilities that you didn't expect until they were 70 or 80. Telomeres again. All of that was going on. And because all that is happening earlier, they die younger. People with veterans with PTSD live 10 fewer years than veterans who don't have PTSD. 10 years. That's what the ACEs pyramid showed. And so more ACEs, you have more problems. Some of them are synergistic. You have, for example, childhood sexual abuse and domestic violence, those people have greater risks than the people who don't have those two as a pair. The worst one is childhood sexual abuse. So they're not all weighted equally. The worst thing that can happen is childhood sexual abuse. And that leads me to the subject of complex trauma and complex PTSD. How many people have heard of this? Raise your hand. Some of you, but not a whole lot. This is going to be one of your open your eyes moments that I want you to have. So what is it? What does it mean to have complex trauma? Complex trauma means that you have been exposed to severe stressors in your life, and usually it's repeated, but sometimes it's just that it's prolonged, as in torture. And they involve some kind of harm from the people who are responsible for taking care of you. And it happens at a developmentally vulnerable time in a person's life. Now, you could say that it's that 0 to 5. That's a developmentally vulnerable time because the limbic system is developing. But actually, we have brains that keep developing. So, for example, any of you have teenagers at home? A couple of you. And any of you ever had teenagers? Okay, you all will know what I'm talking about. Okay? When you're a teenager, they have these interesting characteristics. They tend to be impulsive, they tend to take risks, they don't think ahead to their consequences, they don't do a great job of problem solving for the most part. And you look at them, and how can you do this? You know, you just can't believe some of the behaviors that they do. And then I tell you, at age 16, this part of your brain that I've been talking about the whole time, the prefrontal cortices, that's only 60% developed. 60%. So all of that stuff about risk assessment and inhibition and thinking about consequences that can happen, all of that stuff, they literally have 3/5 of the capacity that you do. It's a capacity problem. That's why a few decades ago the Supreme Court said you could not give somebody who committed a murder as a teenager the death penalty because there's not enough brain there. That's a really helpful to me when I had my teenagers to know this fact. I had to keep reminding myself it's capacity. You think I'm kidding about stuff, but like I learned from this. You know when a brain is fully developed? 26 years of age. That's when you have all of them. So you go from 60% to 100% at about 26 years of age. My middle daughter, who was one of those difficult children, very difficult temperament, she was the oppositionary one. She was the defiant one. She was the one who got into some trouble. And you know, she was never going to, when I grow up, I'm not going to do anything like you. I'm not going to be like you. And when she got to be about 21, she said, Dad, I want to tell you something. What's that? And she said, well, you know how I told you you were always wrong? I said, yeah, I remember. Remember that? She said, well, I want you to know that you weren't always wrong. At 23, she says to me, Dad, I want to tell you something. She said, well, she said, Dad, you were actually right a bunch of times. At 26, she comes to me and she said, Dad, you were right most of the time. But I took this very seriously because same daughter, I developed a rule. And the rule was, I looked at our families, and I was thinking about this 2016, and how a brain is maturing, and I said, you know what, all of the divorces in my family, my wife's family, they all happened when people married prior to the age of 25. Now, I'm not saying that there were people who married before the age of 25, you know, were married for 50, 60 years. But all of the divorces happened that way. All of them. was really struck by that fact. And so I started, checking out with other people and their families, and sure enough, it was the same story in everybody's family. And I realized it's just the brain. So I made this rule. If you want me to pay for your wedding, you have to be 25 years old. You think I'm kidding, but I'm not kidding about it. This same one fucking me, 21, she wants to get married. I said, well, you can get married. Just go pay for it. Figure out how you want to do it. Yeah! And this went on. And these days you have to get a wedding venue before you can start. And you have to wait a year to get a wedding venue these days. And so I'm not going to go on the and so she wanted a big wedding, and so did her husband. That's fine. And they were looking, and they could only find one time that was within a year, and that one was in May. And my daughter's birthday was in June. And I decided, okay, she's been with this guy for 6 years. By this time, he was a really good guy. She couldn't find anything better. And I knew who she was. And I said, okay. You could do it in May. It's a month early. You can go ahead. And she had giant hissing. This huge temper tantrum, started yelling at me. I was inconsistent. I was sticking to my guns. She couldn't believe. No, she was not going to get married in May. She was 24. Okay? So they did it the next year. That's fine. And then last year, and she's now 30. So, brains finally developed. And she said, Dad, I got to tell you something. I said, what's that? And she said, you know that thing about how you wouldn't let us get married, or you wouldn't pay for our weddings until we were 25? And I said, yeah. She said, we're doing the same thing with our 2 daughters. The brain matures. Okay? It really does mature. The problem is that we're developmentally vulnerable until we're 25 and the brain has matured. And I saw that in all the veterans that I worked with. Why? When they went into the military, they were 17, 18, 19, 20. Maybe they were 21, 22. You know how few people go to the military after the age of 25? Very few. Very few. You know why? Because you take an 18-year-old and you say, go run up that hill, they say, yes, sir, and they run up the hill. You take a 25-year-old and you say, go run up that hill, and the 25-year-old says, a 4. Why? I mean, really, it is a brain difference that exists. Okay? So I define developmentally vulnerable, especially because I have seen complex trauma happen in people who were in war when they were in that 18 to 25 range. And they had 2 main traumas. So what is complex trauma? Multiple traumatic events, and it occurs within the caregiving system. In the case of the military, I learned very quickly, it's your sergeant. That's the caregiving system. They're the ones ordering you. So this is my slide after Bruce Perry, and I went into some depth before. I just wanted to show you that this is what I came to understand. So what I came to understand is that if you have a trauma, and the next one is too close, combat, child sexual abuse, getting beaten up regularly in school, whatever it is, if it's too close, the trauma doesn't have time to come, the arousal doesn't have time to come all the way down. It gets interrupted by a new arousal. I mean, school can be a very scary place for some kids. New arousal. Stepdad keeps coming into the bedroom. New arousal. And what happens then is the whole system, the nervous system, shifts. So people say that, when people have a lot of PTSD, they say they have a short temper. or they have a short fuse. And the end, yes, they do. Why do they have a short fuse? This is why they have a short fuse. They say I go from 1 to 10 like this. Well, yes, you do, except you don't go from 1 to 10. You go from 5 or 6 or 7 to 10. And that's why it's so fast. That's why. Now, think of the people you're working with in your courts who have histories of violence or sexual assault or whatever it is. That's what you're seeing. I heard a story this morning about kids who were at a party and they flashed their guns and they were told to leave. And then they started walking out and one of them turned around and started shooting people. Well, because there has to be a party. Because there has to be a party. It's that. That's what happens. So, many different kinds of trauma that people can have, and so there are many ways of getting there. These are the most common ways: sexual and physical abuse, domestic violence, ethnic cleansing, rape, torture, and being held hostage. Those are the worst. If you have multiple trauma types, and there are 17 different types of trauma, multiple trauma types, well, there you can see 22% of a representative sample of more than 2,000 children. So basically, 1 out of 4 to 1 out of 5 in the past year had 4 or more types. Past year, 4 or more types. That's really bad. There was another sample in the basic series with lots of kids. 30% had 5 or more, 10% had 11 or more. I've worked with people who have 17 of 17, and they are a mess. They're a mess. They take years and years of treatment, and they get better. And that's really important for you to hear. They get better. You're going to have all of these kinds of things. I talked about the ADHD and how it gets misdiagnosed. And you find that if you have complex PTSD symptoms, well, you have a history of childhood maltreatment, you're much more likely to have substance abuse. So I think of this as the catalyzing effects of multiple different traumas, okay? And this is my not so great attempt at making something look like a pool table. Okay? And some of you just recognize that thing because it's not such a great thing. But that's a pool table. And you're going to see that I have put the problems that people get: the mental health problems, the substance use problems, the relationship problems that people have, and then we get health problems, that's the cases, criminal behavior, employment problems. Okay? There it is, there's criminal behavior. But the problem is that the more of one of these you have, it is very much like breaking the walls apart. They all start hitting each other. The more of one you have, the more likely you will have another one. And then I started realizing, okay, so that's a traumatic experience. That's the kid ball. That's where it starts. Guess what? Multiple traumas, multiple times. You can fill that up with 2 lines. Just marks these all. Now, complex trauma, I want to be clear, is not the same thing as complex PTSD. It is necessary to have complex trauma in order to have complex PTSD. But complex PTSD is actually a diagnosis. Complex trauma is a set of experiences. You cannot have complex PTSD without complex trauma. So complex PTSD is the effects of those experiences. There has been a move, Bessel van der Kolk of fame, calls it developmental trauma disorder. And we know that it's about 1/3 of people who have complex trauma who are kids do meet criteria for developmental trauma disorder, even though that is not in the DSM but has been studied for the DSM. for a couple of decades. So more types of trauma lead to more problems. And there are certain things that make you more likely to develop complex PTSD, which I'll define in a moment. Guess what? ACEs are there. And of the ACEs, what's the worst? What's the most common? Actually, it turns out emotional abuse and physical abuse are the most common. But the worst one actually is sexual abuse. The only one that is adult is sexual assault. In other words, if you didn't have it in childhood, sexual assault is the worst trauma you can have of torture. So, here are the differences. If you have complex PTSD, you have everything that I described in PTSD earlier today, and 3 other things that collectively we call disturbances in self-organization, or DSOs. One of them is emotional dysregulation. Remember the limbic system? There it is. Similarly, one of them is relationship difficulties. That's the limbic system too. Childhood attachment or reactive attachment disorders. And also, there's a negative self-concept. It's all those negative thoughts about the self. And people who have all 3 of those have what we call complex PTSD. You might ask, is it possible to have those 3 and not have this? Nope. Nope, it's not. I'll show you some data in a second. So, we live in the era of what is called the International Classification of Diagnoses. Does anybody know what the ICD is? The ones who know are the clinicians, right? So, how many of you have heard of the DSM, Diagnostic and Statistics? You know that that is not the law of the land. We cannot make diagnoses since 2012, when the Affordable Care Act came about, because we joined the rest of the world. The United States has had this, well, I would say the psychiatrists in the United States, and my dad was a psychiatrist, but the psychiatrists, and there are many psychiatrists who are close friends, and I give them a hard time about this. And I said, why do psychiatrists think that we can have some diagnoses that exist in the United States that don't exist in the rest of the world? And why do you think that the rest of the world has diagnoses that somehow magically do not happen in the United States? And that's the difference between these 2. And so in 2012, we started having to use what was called ICD-10, that was the International Classification of Diagnosis version 10, because they had been through a whole lot more than our DSM, which didn't reach version 5 until 2015. And they moved complex PTSD as a condition for further study. The rest of the world had been saying this, and the American psychiatrists said, nope, we don't have that here, we don't see it. You want to know why they don't see it? Anybody who's read the DSM, I have read the DSM, I'm sorry to say, painfully so. It's all something you treat with either medication or transmagnetic stimulation or electroshock therapy, but not any of them, all of them can be treated with those things. The problem is complex PTSD cannot be treated with medication alone. It's not possible. It's the damage that happens to a person's brain, to their inner mind, and I dare say to their soul, from all of this trauma. So in ICD-11, which took place, which became the law of the land on January 1st of 2022, so we've had it for 3 years now. Here are the PTSD characteristics, very similar to what we have in the DSM, and here are the complex PTSD symptoms. That is what complex PTSD is. And so when you see these things, the next thing that happens in the trauma tree is complex PTSD. The thing that happens after that is personality disorders, so-called. Now, I'm I'm not a fan of the term personality disorder. I have met people who are truly psychopathic, and that's that 10 to 15% who can't feel pain and can't feel happy. I have met those. I'm not saying it doesn't exist. I'm saying it's not everybody who has an antisocial personality disorder. You can see here data on borderline personality disorder. 81% of them have histories of childhood trauma. Antisocial personality disorders predicted. Multiple studies. The thing you find, the most common thing in their histories is childhood trauma. 73% have histories of child abuse. So personality disorders, I would like to suggest, are not personality disorders. And I would like to suggest to you that we really need to drop this notion entirely. Because I can define all personality disorders to you in 4 words. And the 4 words are, we don't like you. There are all sorts of reasons why we don't like you. And personality disorder also suggests, oh, it's a fixed part of who you are, and it's never going to change. However, we find in our studies that if you say these people have complex PTSD, number 1, the therapists become more hopeful and think they're more treatable. And number 2, the data says they are more treatable. If we shift from the stigmatic label of personality and stop using it, and instead saying this is a person who has experienced horrible traumas in their life for a long period of time, and their brains have changed and their behaviors have changed as a result, and we need to treat their trauma, we can change them. Let me get that. So you take the same tree. What comes next is borderline and antisocial, and at the very end is something that we call dissociative identity disorder. Used to be called multiple personality disorder. It's a very rare condition in my life. I've been doing trauma. I started working with traumatized kids in 1976, so it's a long time. God, wow, I'm going to have 50 years. Okay, that's scary. That's a long time. I have a person with DID right now. She is one of the 3, and her trauma history is just horrific. It's just horrific. And she's a mess because, she'll move from one altar to another, and that's not a good thing. It's not a good thing. It's also important to talk about this notion that PTSD and substance abuse start intermingling with each other. And I just want to show you some data on it. Samsa said over 20 years ago that co-occurring disorders are the rule rather than the exception. We try to treat things and we say, okay, here's PTSD, we'll treat this. We have substance use, we'll treat this. And in our systems, we don't do nearly enough integrative treatment of treating the two at the same time because they're interlinked with each other. And I have a whole presentation that I could just talk about the interlinkages, and there are many, and what that means for how we need to treat them. Has anybody ever heard of a treatment called seeking safety? Okay, so that is the treatment, okay? When you get these people, you need to give them seeking safety. And I'll talk about seeking safety more in a little while, but that is the first treatment. Comorbid disorders are the rule rather than the exception for people with PTSD, but men who have PTSD, only 15% of them have PTSD alone. The other 85% have other comorbid disorders. 55% of them have 3 or more comorbid disorders. I worked for 11 years as PTSD substance use specialist. All I did, let me tell you, people said to me all the time, that was the rule. Send up to my all the things. And the thing was that they were eminently treatable. That was really the striking thing about them. I mean, they suffered more, their behaviors were more problematic, they got in trouble with the law a lot more, that's for darn sure. And their average number of diagnoses was 6. And I want to assure you that there's no treatment in the world for 6 different mental health diagnoses. We're lucky to be able to seek safety and that only treats two at the same time. There are just lots of numbers here about the occurrence of the two. The most important thing is to say, if you've got one, you're much more likely to have the other, that you're much more likely to get substance relapse if there's PTSD, and the treatment outcomes are much worse. So here, something called the National Comorbidity Survey was done by Kessler and his colleagues in 2005, and this is what they found. If you're talking about PTSD and you're a male, half will have alcohol abuse. If you're talking about women, it's closer to a quarter. If you're looking at drug use, for men, it's about a third, and women, it's also about a quarter. So women don't use drugs, they use alcohol much more, relatively speaking, compared to men. But you end up with, it's much worse for men than it is for women. And we do know that PTSD and substance use, you end up with this downward spiral. What you end up having is somebody has an episode of PTSD, and then they want to drown their sorrows, so they go and they get drunk, and they get drunk, and when they get drunk, their inhibitions are less, and then they get into a fight, and they get hurt in the fight, and now then they have some trauma from the fight, and so what do they do after the fight? They go drink more alcohol, and so that's why you get a downward spiral. We also know that they're much more likely to be unemployed, drop out, homeless, have HIV risk, and incarceration. There we go again. It shows up over and over and over again. So this is the pathway that I've come up with. I don't actually think that the IOM one is clear. But the pathway starts with childhood. When you have childhood abuse, you are much more likely to develop PTSD, and you're much more likely to get traumatic brain injury. If you have those things happening, then you're much more likely to end up with legal problems, as I showed you before. However, childhood abuse is going to lead you to other things too. Sex work, I shouldn't have said sex work, I apologize. Sex work. If you had childhood sexual abuse, you're much more likely to be involved in sex work. And if you're more likely to have sex work, you're more likely to have legal problems. If you have sex work, you're also much more likely to develop PTSD from under treatment. And that then gets you over PTSD, and that then gets you over to substance use. Substance also exacerbates the PTSD, and it leads by itself to legal problems. The sex work also leads to substance use directly. The sex work also leads to experiencing violence, because often people who are sex workers get beat up. And that violence can end up in legal problems. The violence can also create more PTSD and more traumatic brain injuries, and those also create more violence. It's a reciprocal pathway. Same thing with substance abuse, reciprocal pathways. Childhood abuse is directly related to substance use. In fact, you know what the best predictor of substance use is among all the ACEs? It's childhood emotional abuse. Emotional is much more likely. You can also end up much more likely, if you've been abused as a child, you can end up with military service. What does that end up with? Well, that ends up with combat trauma. It also ends up with military sexual trauma. And those things lead to substance abuse, they lead to violence. Military service can also lead to violence. Okay, that's what it looks like. It's a complicated web of how these things interact with each other. Or more. Oh, the other one is accidents. Much more likely to have accidents. And guess what? If you have an accident or DWI, you have to be. So I talked about veterans and how they are a special case. I'm going to only go over this briefly. quickly because I want to make sure that I get to the parts about treatment. But one of the things that is fascinating is veterans end up being arrested more than the general public. And in fact, if you look at the histories of every war in this country until the recent wars in Iraq and Afghanistan, you would get a massive influx of veterans into the prison system, into our jails, after the war was over. Why? Because we conditioned veterans, we trained them to use violence to solve problems. And what we don't do is we don't decondition them when they come out. And so they're using violence to solve the problems, and that gets them in trouble. And they have higher arousal levels, so they're much more likely to be violent. In fact, the Army has known about this higher arousal stuff forever. So they ended up creating this concept. And the concept was what they called dwell time. And what they learned is how much time do you need to have between one set of traumas and another set of traumas in order for their arousal system to go down. And what did they find? The number is 1 year. You needed 1 year between tours for your arousal system to calm. And if you look at our last wars, it could be as little as 2 or 3 months. I treated people who had as many as 13 deployments in 12 years. Now, the problem with that is we all only have just so much in it. We actually know, the Army has figured out how many days consecutive do you need to have consecutive combat before everybody in the unit, everybody has a breaking point. It's really important to understand that. Everybody has a breaking point. How many years, how many days, I'm sorry. And the answer is 76. 76 successive days, and the entire unit is psychiatric tension. The entire unit. And we have these wars going on and on and on and on. They were sent back before they were ready. Their arousal systems did not calm down. We sent them back. If we look at folks who are in the Army, we find out, in fact, as I said before, that there's a lot more than half of people have histories of child abuse. Women tend to be larger than that. We find that incarcerated veterans are very likely to have histories of physical abuse, especially. 77% of incarcerated veterans have histories of abuse. It also results in combat, results in more substance use. Why? Because you're using the substances. They don't use stimulants except to stay up at night. That's when they use the stimulants. They tend to use things that bring them down from the high arousal level. And the number one thing they use is alcohol, which is a depressant. That's what they use to bring and calm themselves down. Many of them will do it so they don't have nightmares. Some of them will do it because they can't sleep. And they think if they get drunk, they're sleeping. And actually, it's not true. They're knocked out. Chemically knocked out. And here's the worst end of it. So this is from the Institute for Veterans Policy. And it basically says what I said. You know, using tactics like hypervigilance, rapid response to threat, those things enhance survival and combat. But because they do that, those same things make people more likely to be arrested and incarcerated. The same survival skills that work in a war do not work in a non-war civilian setting. So now we're going to get to solutions. This is the Pandora's box. George Buck's presentation because I've spent all this time telling you about all these horrible things. And by now I've probably exhausted some of them. And I want to let you know that there is hope. And the hope comes from good screening and assessment so we can identify who these people are. And then it comes from good treatment. So I'm going to talk about screening and assessment first. We have to identify these folks. And in order to identify them, I have put up here 3 questionnaires that you basically have to use if you're going to have people review. Anybody here working treatment courts? Okay. I'm talking, wait, hold your hands up because I don't see who you are. I'm talking to all of you. Okay? All of you need to memorize this in the next section. Now you will get copies of it, okay, so you don't have to memorize it. But this is for you to understand. For the rest of you, it's to understand that people are really treated, eminently treated. But I'm going to be much more explicit about what do you do and what must you know and practice in order to help people with this. So, screening assessment tool. Number 1, the ACEs. You've already seen the ACEs. I don't need to tell you about the ACEs. Number 2, the life events checklist. It is that I mentioned to you that there's 17 different types of trauma. It's on the life events checklist. And number 3, the International Trauma Questionnaire. And I'm going to show you all 3 of these. The reason you have to have that one is because it was the instrument that was developed to split out PTSD and complex PTSD and see who had which. And that's really important because when you have somebody who has complex PTSD, they will always relapse more if they use substances. They will always take more time in a treatment court because it takes a lot longer for them to get safe and stable. So, those are the 3. So what are they? Well, there's the ACEs again. You saw that before. And this is what it looks like. It's a single sheet of paper. I recommend that when you are doing this in a treatment court setting, that what you do is you simply pass the sheet over the desk and have them fill it out. I've discovered that it's amazing. If you say to somebody, so did any parent in your other adult in your household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid you might get physically hurt? They'll lie. They'll lie. And if you pass it across the table, I get an average of 2 more ACEs for people I pass it across the table to than for people who I pass it. So I always pass it across the table. I mean, especially number 3, because it talks about somebody attempting to touch your body in a sexual way, or oral, or anal, or vaginal intercourse. People don't want to suggest that, especially if they're married. Especially if they're married. That is what the ACEs looks like. The life events checklist basically has 17 different kinds of traumas. And what is nice about it is that it also says that whether it happened to me, whether I saw it happen to someone else, that can be traumatizing. This is what happens in your courtrooms, right? In your courtrooms, you see these things. Or, number 3, you learned about it, you hear about it. And you can be traumatized by that too. It takes longer usually, but you can be traumatized by that too. And I was dealing with that yesterday when I talked about what is called secondary traumatization, when you hear about it from somebody else. But you can end up with PTSD from that too. And so you all have to be careful. And you have to be careful. I listed those vulnerabilities before for you. Well, the same thing is true. And when you look at people who get into our field, how many people, grow up and say, I want to work with people who've been traumatized. Or I want to work with people who are going to be in the criminal justice system. 5-year-olds don't say that. They may say they want to be a policeman, but they don't talk about the people who are doing the work. I want to defend them. I want to prosecute them. That's not a life goal. Why do we do it? Because something happens to us or someone we know. Either it happened to me, I saw it happen, or I heard about it. And so all of you, I'm sorry to say, most of you, have some vulnerability. And I include myself in that. I include myself. I heard about my father's family and all. And it was right. And that's why I'm here. That's how I got here. It's a simple story. So you get all of these things. It does nicely say part of my job, because that is what a lot of our policemen are doing. And it allows you to say it doesn't play. What the LEC-5, the Life Events Checklist, does is it measures your trauma load. Remember I said 4 or more types of trauma is the breaking point. The more you have, the more likely you are to get to complex PTSD. And then there's the International Trauma Questionnaire. It came out in 2018 or so. It has 6 questions for PTSD and 6 questions for what? Their disturbances in self-organization. And they measure intensity of symptoms, and you get scores. This is what it looked like. And this one does describe this experience, but you can do this over and over and over again. And here's the thing. If you're in a treatment court and you want to develop a treatment plan, and you do not know who has complex PTSD and who has simple PTSD, you're out of luck. You're giving 2 very different groups of people essentially the same treatment plan, whatever it is. And that is a giant mistake, because these people with complex PTSD, as I showed you, have worse outcomes in many ways, and they're much more likely to relapse and have other kinds of problems. And if we don't stick with them, we're not going to be successful in the treatment. That also means in a treatment court, you have to think about what you can do, because you are time limited. New Mexico law limits the amount of time that you can have somebody in your treatment for. And so you have to start thinking about what is accomplishable within the time frame that we have, 18 months, 2 years, whatever the time frame is. What can we accomplish in that period of time? It's really important to be able to answer this question. The other thing that I recommend to treatment courts about this is that you consider having the complex PTSD people go at a different time, or at least come in before the other people come in, the ones with simple PTSD. And that is because we all compare ourselves to other people. It's a natural thing. We're often, in our childhood, we're sort of placed against each other. Oh, who gets the A's in the class? Who's the good athlete? This comparison stuff happens all the time until it becomes automatic. And the problem is, if you're a person with complex PTSD, you're going to advance slower than the ones with simple PTSD. And if you advance slower, you see these people are getting way ahead of you. You start feeling bad about yourself. And remember what I said, one of the features of complex PTSD is negative self-evaluation. So now you've reinforced it and you've made it worse by putting them together. That's why you can't put them together in our treatment courts. You let the people with complex PTSD go first, then you can have the people with simple PTSD come in. You can dismiss the ones with complex PTSD. You can let them go. It's a much better way. And by the way, always put them first. Complex PTSD ones. Why? Because the people for the next trial are going to filter in if you run over. And that's what happens. Anybody can walk in to any trial, any court. They can walk in because they're public. And so you have other people start walking in. It's not a good thing. And by the way, if you're a judge and you have a treatment course, please never, ever, ever schedule a murder trial or a rape trial right before, because people will start coming in and you don't want to re-traumatize them. You really have to think about these things. What I am talking about is a notion that we call being trauma responsive. And it is a pretty new notion. It really only existed over the last 3 years. But if you are truly trauma responsive, you are responding to things like the differences in people around their trauma and responding by acting in a different way towards different people because they need something different. I kind of said this. Specific trauma treatments will vary depending on the type of trauma. I talked about that, and I just talked about that. Okay. So now we get to treatment. Finally, at the bottom of Pandora's box. Okay. By the way, all 3 of those assessments are free. And I do have a page. I have like 15 pages of resources at the end of this. And I give you links to all of them. All I have to do is click. Yes. They will. Treatment. I have told you that these people are treatable. Now I'm going to prove it to you that they're treatable. There are 3 stages of trauma treatment. This comes after a woman named Judith Herman. She put out a book in 1993. And it is an extraordinary socio-political, clinical critique of our society. And it talks about intergenerational trauma. It talks about cultural trauma. And it talks about historical trauma. And it talks about all of the different kinds of trauma and what they do to people. And she literally reconstructed the field and came up with this notion of complex PTSD in the book, and trauma and recovery. And I will tell you, I probably have a little bias again for this, because in 1989 I was doing my clinical psychology internship. And I intentionally chose an internship. This one was very famous, Dr. Herman, where she was. I got to have her as a group therapy supervisor. So she consulted on my cases. And when I read the book in 1995, I went, oh my gosh, this is the most brilliant book I've ever read. I mean, it's an extraordinary book. If you're a clinician, you haven't read this book, you don't understand trauma at all. And it's been out, 30 years. It's an amazing book, what she did. And it wasn't just me. The New York Times critic, who reviewed the book, said that this book, Trauma and Recovery, is the most important contribution to psychiatry since Sigmund Freud. It's an extraordinary book. If you are interested in the notion of trauma, and you can withstand what is going to be trauma exposure, you're going to read about it, or you're going to hear about it. That's the book. It's listed in the resources. She, in this book, not only created the idea of complex PTSD, which we now have, took a long fight, but we got there. She said, you have to treat these people in 3 different stages. The first stage you have to treat them is what we call safety and stability. Why? On the safety side, they hurt themselves and they hurt other people. Here we are. It's that simple. One of the ways they hurt themselves is through substance. But there are many ways that they hurt themselves. Some quite directly, and others that are more indirect. Stabilization, I'll get to in a moment, but it means something different. It means, the simplest way, example I have is that if you have somebody who is unhoused, it is not time to do trauma treatment. You can have somebody talking about what the worst things in their lives were when they're looking for their survival. Where am I sleeping tonight? That is safe. And where am I getting my food from? That's true survival mode. You cannot do that. This is, this is a pyramid of survival. And you can't do that. You have to have them safe and stable before you can do what we would call trauma processing, what she named remembrance. And finally, there's a stage called reconnection. I can promise you that no court ever gets it. I know that. No court ever gets it because it takes so long. If you have something with simple PTSD, 1, 2, or 3 traumas, you can get them, if you're in treatment, or you can get them into this part. And they may even complete this part. I've seen it for some of them do. And they can get through it in 18 to 24 months. And that's great. You have somebody with complex PTSD, they may never make stage 2. I have people I've been treating for 10 years, I still can't get into deep level stage 2 work. I can't. I've tried, but it's really, really hard. So, for complex PTSD, this one is the longest. For simple PTSD, both of them are required here, but the simple PTSD trauma processing is the longest. So I'm going to give you the very short version. I'm going to give you the answer. I have spent 30 years in this field, 34 years in this field, and that doesn't count all the stuff I did with people, treating people who were traumatized before I had cancer. And the answer comes from an article in 2015. The article was from Brown and colleagues. They did a 12 to 18-month drug court program in the state of Washington. Hang on if you're going to take a picture, because I have more to show you. And there are many people in this slide. What they did is they took seeking safety, which I will get to, and they gave it to 150 of their participants from history, and out of them, 75% of them completed seeking safety. That's good. They also were offered something called eye movement desensitization and reprocessing. I'm going to explain that one in a moment too. I'm just giving you the answer. I'm giving away the game, okay? And then I'll explain why these things will do. And 58%, 3 out of 5 agreed to do it. And the graduation rates in treatment courses have 2 different goals. Goal number 1, graduate. Goal number 2, don't have them come back. You don't want them to recidivate, right? That is really, really important. Incarceration is not a successful treatment for recidivation. It is not. So, of the 65, and this is about graduation, who engaged in EMDR, 91% successfully graduated. Show me a treatment course with a 91% success rate of graduating. 9 out of 10 of their people. And I'll show you that for you. And that's the only one that ever has come close to that number. Some veterans treatment courses come closer, 85%. Of the 47 who didn't, only about 3 and 5 graduated. In other words, if you didn't get to the EMDR, and you had to do the seeking safety first, but if you didn't get to the EMDR, you didn't finish it, then graduate. Who were those people? I can tell you who those 43% are. They're the ones with complex PTSD, but they didn't make, and I am now doing the study to prove what they said was right, except that they didn't make that one essential distinction in 2015. Here is the other thing. The recidivism rates differ. So, They actually had 72 people, it's hard for me to believe, but said they had 72 people who had no trauma history. I don't know. But about 10% of them recidivated over 2 years. Now, that is a great recidivism rate. You know what the normal recidivism rate is? In criminal courts, anybody have any idea? 50%. Half of all people come back within 2 years. Half. That is not a successful intervention approach if your goal is not to have them back. Now, the other thing that people do with that goal is, to put people in prison for life. And I'm not questioning that there are people who need to be put in prison for life. Believe me, the last person already that. However, we aren't clear about this distinction, which is so important. So if people did seeking safety and they did EMDR, only 12% recidivated compared to those without trauma, 10% recidivated. That is not a significant difference. In other words, if you give people seeking safety and you give them EMDR, you give them both, you make them in their outcome, number one, graduate, and number two, in terms of recidivation, you're going to have the best recidivation rate you can have, which is people without trauma. Oh my goodness. The answer is very simple. Getting this put into place is another issue. Of those who did seeking safety, they did better than the average people. Seeking safety did have an effect because they had a 1 out of 3 recidivism. It wasn't a 50%, it was a 1 out of 3. So did seeking safety alone help people? Yes, it did. Did it make them look like did we get them all the way back to, no, you don't have trauma anymore? No. And I'm going to show you why. So there it is. This is the solution. This is the solution. If you're in a treatment court, you need 2 treatments available to treat the trauma. And the first is seeking safety, and the second is EMDR. That's what you need. I'm not saying you don't need substance abuse treatment, but seeking safety takes care of most of them. I've had so many people who failed substance abuse treatment, and they would send them all to me, and I would put them in my seeking safety group. And 3/4 of them would be successful getting off all the substances by the time I've done 12 sessions with them. And one of the other 2 would be reduced in their substance use, and then there'd be that bang one. And if you're a clinician, where's the clinician? Yeah, I'm going to tell you who that one is. It's a really interesting thing. When you do seeking safety in a group, the single most oppositional person will sit opposite you. They always take the opposite part of the table. And so I know from the very beginning of every seeking safety group who's going to be the biggest pain in the room. And this is what it looks like. So I wanted to have a visual for this because, 10,000 words and all that stuff. So people with histories of substance misuse and misuse of trauma, we give them seeking safety. They also have PTSD after. Then we give them EMDR, and then they graduate and they don't recidivate. Now, I have another version of this, which I am not showing you because it is a place where I have realized, okay, what do we do about the complex PTSD that I've been telling you about? We need another line here. It says complex PTSD, and up here, you put something called dialectical behavior therapy. And that is built for, guess who? People with disturbances in self-organization. And so we know we need that in there too. As I said, I'm doing some research on this subject right now. In fact, I have 2 places which are, actually I have 3 places that are now doing it. One in Rhode Island, one in Indiana, and the other one is New Hampshire. So, how do we treat PTSD? And a lot of people will say, well, you throw a bunch of medication at them, and I'm not really convinced about that whole thing. In fact, we used to use something called atypical antipsychotics. We know they don't work, but they do work in helping people to gain weight. But otherwise, they don't change PTSD. You just gain weight. We used to give them the benzodiazepines for their anxiety, and you know what we did? We created a mass group of people who have addictions who had to take more and more benzodiazepines, but they never got better on the PTSD. Never got better. Doesn't solve the problem. It takes away the symptom, but it doesn't solve the problem, and then it creates an addiction, which is not a good idea. There is no medication for PTSD. We just use something that happens when outside comes in, affects your brain, affects your body. And all of that corticosteroid bath, we don't have anything that can undo that. But we do know we can treat symptoms. Prozac can treat the depression. Paxil can treat depression and anxiety, and prazosin can treat nightmares. That's it. And we're talking symptoms. Okay, so I'll just talk about their symptoms. That's all. And we've got 20 symptoms that are saying. This is Seeking Safety. This is the manual by Lisa Nadjovitz. Came out in 2001. It's got 25 different lessons. Every lesson covers both PTSD and substance use at the same time. So, for example, safe coping skills. There are 84 safe coping skills that we teach people. I probably, in 12 lessons, can only get through about 60 of them. If I do the full 25 lesson version, I can get through them all. I tell people, start figuring out which ones of these are useful for you. And sometimes I will assign them to do these ones. So I had a veteran, and this was a guy who he had a horrible alcohol problem. He was really badly addicted. He had been to residential twice. He had been through intensive outpatient programming 3 different times. And they said, well, we didn't fix him, so why don't we send him to Dr. Meyer? And the funny thing was, I had a trainee sit in with me. And the trainee had watched him fail before. And she said to me, you can't help this guy. And I said, has he had Seeking Safety before? She said, no. And I said, well, then don't tell me I can't help this guy. And it was the funniest thing. So he came in, and he was really angry. And he was really angry with his wife. And he was angry with his wife because she wouldn't have sex with him. Why wouldn't she have sex with him? Because she didn't like having sex with him when he was drunk. And he was drunk all the time. He would drink 24 beers a day to 30 beers a day. Okay? Now, if you start doing that today, you start going 24, 30 beers, I promise you that you will be over the limit, of the legal limit of how much alcohol. In fact, he's over the alcohol poisoning limit at that. And he's still partially functional, partially. So at the end of the first lesson, I say to him, I like to say to people, pick one of these. And I said to him, in your case, I'm going to pick one for you. And I want you to try this safe coping skill. And the safe coping skill was called use kinder words. And I said, I just want you to go home and use kinder words with your wife. And I want you to come back and tell me what happens. Okay? That's all I want to know. And I do for everybody always ask at the beginning of every session, did you use any substances? What did you use? How much did you use? And, I always ask, if they're drinking beer like this guy did, is it 12 or 20 or 40? That's a really important question. But I also have to know what the standard drink level is. And so, okay, so I do this. He comes back the next week. And I said, how'd it go? And he said, well, I used kinder words, but she didn't. She wasn't nice to me. I said, I'll tell you what, let's try it again for another week. The reason I want you to try it for another week is because, she's kind of used to you drinking a lot all the time. And she maybe thinks, and she's still seeing you drink, she maybe thinks that this isn't real, he's just trying something on me, so I'll go to bed with him. Which is exactly what he was doing. And so we came back the next week. So now we're in week 3. And I asked him how to go. And he said, well, I used kinder words again. And I said, well, how about your wife? He said, well, there were times when she was nicer to me, and some of the times she was just the same. And I said, good, keep doing it. So he goes back the next week. And what was really interesting was that 3rd week, he went from 24 beers to 18. I didn't tell him to quit. I did not tell him to quit. I told him he was trying to quit. I didn't tell him to reduce. So he goes back, and now we're in the 4th week. And I asked these questions in a separate point in the session because I don't want him to get them confused because I know what I'm doing. And I don't want to be able to do it again. And I tell him, and so he said, what happened? He said, well, I was nicer to her, and she still wasn't as nice to me, but it wasn't as bad, and she kissed me once. I said, good. Do it again. Week 5. Oh, and by the way, that week he's down to 265. I'm not telling him to do anything. That week he's down to 265. So he wasn't as strong. So I tell him, do it again. Week 5, he comes in. And he said, we had a date. And I said, yeah, what happened with the date? Can you go a little bit about it? But she still didn't sleep with him. But we had a date. And I'd asked him previously, how much was he drinking? He said he was down to 6. I tried it again. You know where this is going. He comes in, he is like swaggering. He's coming in with his body, he's feeling good. And I'm looking at him and going, yeah, yes. I didn't say that. How much did he drink? 0. This guy had been drinking 24 beers 5 weeks earlier. He's at 0. And then we come to his report of his week. And I said, how'd it go? And he said, yeah, great. Man, we had some of the best sex we ever had. We did it a couple of times this week. Things are great between us. She's not saying anything mean to me. I'm not saying anything mean to her. All I did was seeking safety. Okay? And it was not some great fancy intervention. I just told him, be nicer to your wife. Because I knew what would motivate him was what he got. It works. That's the magic of seeking safety. Is that it gives you these tools that you can give to them, and if they practice these tools, even when they're very seriously in the throes of an addiction, you find something that motivates them, and you're off to the races. Did I do any motivational interviewing with them? No, I didn't do any motivation. I did a lot of motivational interviewing with him, but I didn't do motivational interviewing with him. He had plenty of motivational interviewing. It always failed. I'm not looking for failure. I'm looking for success. Just use nicer words. That, by the way, is the upward spiral of recovery. I showed you the downward spiral before. That's what we call the upward spiral of recovery. Is that one thing leads to the next, that leads to the next, that leads to the next, boom. And he stayed sober for the rest of the time I saw him. There are a lot of other things, lessons on different things. You come into court, you're in a treatment court. One of the biggest problems we have in treatment court is people come in with a positive urine drug screen, and then they say, well, I didn't use. That's not me. I didn't. Oh, I walked through a room where there was cannabis. That's where it came from. Yeah, right. I mean, we know better. But We have a lesson that's called honesty. And we know that people who use substances lie. And we know that people with PTSD hide things. And the lesson about honesty is dealing with both of those. Every lesson deals with things that happen in both post-traumatic stress and substance use. Imagine this. It's amazing. She's the nicest human being I've ever met. I ended up cold calling her. I'm a little fearless about calling these people, who are like famous and put themselves together. I cold called her. She sent me 3 chapters of her latest book. It hadn't been published. I do work with her. I got seeking safety into Tanzania. They're doing it right now. And we just got our first results back. And guess what? They're positive. They're positive. It works in other cultures too. Wonderful stuff. It's the only evidence-based group treatment for people with PTSD and substance use. Why is that important? Well, number one, it's efficient. You get more done at the same time. It's better to have people tell other people, you need to do this, than it is to have me tell them, you need to do this. And so groups, I think, are much more effective. Lisa, I know, would disagree with me about that. That's okay. She's right. It's okay. Let's just use her work and it works. That's all. Oops. Yeah, that's the 84 safe coping skills. So what does a group look like? Or an individual? It's weekly. It's often taught in 12 sessions. I will tell you that the research on it is based on the 25-session version, not the 12-session version. Groups are about 8 to 10 members. And here's the killer. This one really gets me. So she has tried it out in other countries as well. And she has tried it out by having paraprofessionals do it. I was part of a project in Texas a decade ago where any POs in the room? No POs. Any former POs in the room? Hey, there we go, okay. So you were former POs, okay. We taught it to POs in 17 different courts in the state. We taught seeking safety too. And then we watched what happened. And dang it, their results were as good as mine. I didn't know whether to be proud or pissed. I sat there thinking, I went to graduate school for 8 years. I paid 6 figures worth of money to get this graduation, and I could have bought a book for $41 and gotten the same results. That just seems not fair. Anyway, it is great stuff. It really is wonderful stuff. I mentioned dialectical behavior therapy, okay? And I'm bringing this into this because it is my full belief that that's going to be the thing that makes the difference for those people in terms of graduation rates, is that they're going to have DBT after seeking safety, okay? So we go seeking safety. But if you have complex PTSD, then you have to do DBT, and then you can do the EMDR in that order. And that's because they take more time. And that's what I said, they take more time. Now, if you look at this, there are 4 lessons in skills training. One of them is called interpersonal effectiveness. Oh, we're talking about interpersonal relationships. Another one of them is called affect regulation. Oh, emotional regulation. What is distress tolerance? It's impulse control. Let's grow the prefrontal cortex. I once talked to Marshall Linehan, who created this, and Marshall Linehan is a behaviorist. She later turned out to have, we found out that she had, in the New York Times, she admitted that she had been diagnosed with borderline personality disorder. She developed this to help people like her. But what she did was really, really great stuff, okay? And it has worked better than anything else for people with so-called personality disorder, better than anything else. And that's because it's hitting 2 out of 3. The mindfulness stuff is basically about calming the nervous system. Anybody practice mindfulness meditation? Okay. Does it calm your nervous system then? Yeah, it calms your nervous That's what it's for, calm that nervous system. I practice it. I teach it. And it really works. I had a guy, I was teaching mindfulness to this guy, to a group. And he was involved in one of the most famous sports fights, and certainly the most YouTube watched sports fight ever in this country, ever. This guy literally came into my group, and he would have a guy he fought with every single day. It wasn't a day if it didn't have a fight with another human being. And I did mindfulness with him, and I won't tell you all of the stories, but 6 weeks later, into the mindfulness group, this guy came in and he said, well, I didn't fight this week. What? Okay, he's having a fight a day. You didn't fight this week. I said, what do you mean you didn't fight? He said, no, you didn't fight. I said, well, how did you manage to do that? He said, well, this guy who you've been fighting over the day. He said to him, why don't you just go and tell everybody you fought me? Because the other guy fought. Tell them you fought me and tell them you fought me. Tell them you fought me. That's fine. Go ahead. Say what? And he continued to be fight-free for the final 6 sessions of the mindfulness class. Why? Because I taught him a different way of handling things. If you look at mindfulness and you teach it to incarcerated individuals in the most heavy security prisons in the country, the max security prisons, the ones for the murderers and the rapists and the terrible people, you do that, you really cut the violence rate in that security prison by 50%. Those people don't have hope of getting out. Most of them are getting out of there. Most of them are on life terms. Might get out when they're older or they're sick, but they can get out very easily. And it has cut the violence rate in half. They taught mindfulness, cut the arousal level. So this is great stuff. I've been doing this, it's really weird because I was doing all this stuff planning before, like other people were doing this. It's very weird. At my VA, I was the first person to do mindfulness, the first person to do EMT, the first person to do EMDR, the first person to do CPT. All of those things. And I brought those things to my VA, and now I train people to do EMDR at my VA. I have people, they go through the training, and then I meet with them every week. I supervise their stuff, and I consult on their work and teach them how to do different things with the EMDR, which brings me up close. You can't begin an evidence-based treatment where we're doing trauma processing until the client is safe and secure. So there are 3, basically, evidence-based treatment that can use. One is cognitive processing therapy, one is prolonged exposure, and one is EMDR. Okay. What is CBT? It is based on a single trauma. That's really important. The assumption in CBT is if you treat one trauma, you treated them all. It's going to generalize. It's a cognitive intervention. Change the way a person thinks. So what are they doing in CBT? They are reactivating the dorsolateral prefrontal cortices. That's what they're doing. They're trying to reactivate the dorsolateral prefrontal cortices so that then they can calm down the amygdala and not make risky decisions. It is taught in a very structured, manualized protocol. You can do up to 15 or 16 sessions. It may or may not address the trauma directly. That's okay. You can do it individually. You can do it in groups. That's really helpful. And you have homework sheets between sessions, basically. And you have to practice changing your thinking. But instead of having this thought, exchanging it for another thought. It also identifies something that we call stuck points. That means basically beliefs that people have developed that get in their way of healing. I'm a bad person, I can't do anything right. The world is a dangerous place. All of those kinds of things. And as I said, they're working here. And in terms of the people who have complex negative view of the self. The problem is that they're not hitting the interpersonal relationships and they're not hitting the emotional integration. And what you find is that it's an effective treatment for simple PTSD. It is very effective for simple PTSD. Now, there's a couple studies that said they successfully completed complex trauma, but none that say they did complex PTSD. Remember, those are different. Why? Because she's a cognitive behaviorist, and for some reason, the cognitive behaviorists don't like the idea of complex PTSD. It's silly. Prolonged exposure. This is a behavioral intervention, and it has really two parts of it. And part one says go to places, usually public places. People have that religion stuff going on. Go to public places and stay there for a long time. And what happens is, if you go there, they go to these places, boom, their anxiety shoots up way, way, way fast. And the point is, they want to get them past the peak to the point where it's going down. Why? Because anxiety exists in this form. It is a wave. And if you wait out the wave long enough, you won't have the anxiety. And so they teach them basically, and here's the thought, which is catastrophe. But if you teach them, wait until you get here, and this is time, and this is how high your anxiety is. Wait until you get here before you leave. And then it goes down. It's a very successful thing if you have 1, 2, or 3 traumas. But if you have more than that, if you have multiple traumas, sexual abuse traumas, maybe many of them came from the same person, but some of them came from other people as well, you don't get past it. So that is called an in vivo exposure, real life. Then what they do is they say, now we're going to, fourth section, now we're going to have you take a trauma narrative. Because this is what they're going to do. They don't want to talk about what happened. And then they have to take it. And then 35% of people drop out. Session number 4. So this one is problematic because we have a huge dropout rate in it. It's a huge dropout rate. Now, for the people who do complete it, I want to be clear, and who have simple trauma, it's very successful. But they have to listen to this narrative every day. You know, take what happens in therapy, do the narrative, and then you have to listen to it for an hour every day. Imagine having to listen to yourself talking about the worst thing that ever happened to you for an hour every day. But we can desensitize people if they don't have lots of trauma. It is a successful technique, although there's no evidence that you can use it for complex PTSD. And then we come to EMDR. EMDR, movement desensitization and reprocessing, came in 1992. It's actually the earliest of these. I learned it in 1995. What EMDR does is it does something called bilateral stimulation across the midline. We have a person who have them, and we don't have them tell us about their trauma. But we do have them picture a moment that identifies the trauma. And I don't even know what they're seeing. I don't care. I literally don't have to. People love that. They also love the fact that, unlike the other two, there's no homework. They don't have to do worksheets and CBT. They don't have to listen to this stuff or go to places to do homework. They just come into the office once a week. And we have to picture that. We really have them state a negative belief about themselves that they associate with that trauma. Okay? Then what we do, and this is really important, is we have them say, what are the emotions you're feeling right now? And what are the body sensations? Where are you feeling discomfort or tension in your body? We have them do a body scan, mentally a body scan. Everybody holds this somewhere. That's the amazing thing. That's what Vanderbilt was like, right? The body knows the story. is somewhere, and sometimes it's more than one somewhere, in these people's bodies, where they hold all the attention. By the way, sorry, this is a normal thing. We all hold our attention in our bodies. Some. And so we use that as a thermometer to figure things out. And then we ask on a scale of 1 to 10 how distressing it is. And then if we're doing eye movements, we will simply take our hands and we can go back and forth. And we have to cross this midline. And it's much trickier than that, and do not try to solve it. Do not try to solve it. Because if you don't know things about how wide eyes should go, or the pace in which they should be going back and forth, or the amount that you should be doing, there's a lot of very technical stuff that you have to know how to make this work, which is why I do this supervision consultation. And things change. That's the weird thing. Things change. The picture may change. The belief may change. The emotions may change. The body sensations may change. And the rating of stress goes down. Things change. We don't have 100% explanation for why that is the case. There are a lot of theories about it. We don't have 100% explanation. Now that we do virtual treatment, we have developed other ways. There was always a way of doing it where you could have people hold buzzers in their hands, and we'd alternate the buzzers, and we'd alternate the buzzer speed and intensity. You could do it that way. Now I have people tapping on the knees, and some people will tap on their shoulders, and that's okay. Some people will tap on their chest as well. But there's a difference between slow tapping and fast tapping, and you have to know what each of them does, because if you do fast tapping, you make that mistake, and you don't have the money for it, suddenly you'll be right into smack into the draw. You have to know how to handle that, which is why you can't do this. There is a book, actually, that she has that will do some techniques. And I have that in the research. We do know that it works for PTSD. We know it works for complex. And we can also use it to address substance use, which is really interesting. So now we come back to the brain. And I told you, and I'm going to say this again. I want you to watch this. And what happens? This is the non-traumatized brain. This is the PTSD. Remember that both of these are being seen from the top. And now I'm going to show you. This is the brain of a woman. She had been raped. This comes out of Daniel Heyman's work. When he took pictures of her brain. Now this one, in this case, it's being seen from the side. All right, this is the front. This is the back. Where is all that attentional stuff? Oh yeah, it's all right there. Where is the hearing? Here it is. Where's the amygdala? There it is. Where's the legs? There they are. Where's the eyes? There they are. This long stripe here that you saw from the top before. There's the hands. There they are. This is the PTSD brain seen from the side. It's the same thing. I'll go back. There's the long stripe. There are all of these other things. And you can see all of that in this picture. It's the same thing. So this is a woman with PTSD. Now, after 4 sessions of EMDR, and I'm not guaranteeing you that this works for everybody, but she had one trauma. That's her brain. That's your brain. What's this? The dorsal line process. What happened to the small one? What happened to the large one behind it? With the exception of this, which I'll get to in just a second, we've already told you. And that's what we're doing. You can't tell me you can't change trauma. But you can't tell me you can't change somebody. I can change somebody's DNA by doing this, or having them tell. That's amazing. That is friggin' amazing. And even if we don't know exactly how it works, we know that it works. People chew the leaves of the plants that we make aspirin from for centuries for pain relief. They didn't know the chemicals that were in it. All they knew is that chewing the leaves made them feel better. You take, like many of us, take medicines. Help us feel better. Do we really know everything that's in that medicine we take? Or do we just believe that this is going to make us feel better? I said, this is the only part that's left. And I will tell you, I really do understand that. That's the attention center in the brain. There it is. And I see this all the time with the people I work with. They are afraid of giving up hypervigilance, because if they give up hypervigilance, they're afraid they'll be unsafe. And I always say, I don't want you to give up your vigilance. I want you to be aware of your setting and any potential dangers that are there. I just don't want you to be ready to run or to hit somebody at the moment that you see it. I don't want you to feel like you have to jump out of your skin to have situational awareness. And I show them this, and then I say, see, you don't have to. You can do EMDR with me, and you'll be just fine. You'll still be alert to the situation. You're not giving up that skill. So, what about courtrooms? And this is a little bit, yikes, we're almost there, so I'm going to just, this is the continuum I think about courtrooms. Courtrooms are either trauma naive, I don't know anything. Trauma aware, yeah, trauma's there. Trauma informed, now you guys are trauma informed. You have enough to be trauma informed. Because you know about the science, you know about the brains, you know what works. Trauma competent or trauma responsive is a different thing. This is the most important question. What happened? Not why did you do that thing? Not what motivated you. What happened that got you here? And as this says 9 times out of 10, the story won't make you angry, it's going to break your heart. These courtrooms must have safety, trust, respect, and a sense of some control. We have to follow the senses 4 R's, realizing about the impact of trauma, recognizing signs and symptoms of trauma, responding by integrating knowledge. This is where we split. This is the trauma-informed court to the left. If we put it into our policies, procedures, and practices, and we actively resist re-traumatization, that is being trauma responsive. We have to change our language in these courts. There are things that we can do. I don't have time to go through all of them. Never, ever, 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 ever ask somebody to tell the details of their trauma. Never. That's all you're going to do is you're going to violate their boundaries. You're going to shame them, because most people feel ashamed of the traumas that they experience. You may re-traumatize them, because now you told them to, oh, just like the therapist did in prolonged exposure. Go play it in your ear, now tell us all about it. And anybody else who's in there in the treatment court is going to get to other participants that you're going to trigger members of the treatment team. Why? Because we all come to this work honestly. Some of us have a series of trauma. And if we prevent it, we've done a lot. We can decrease secondary traumatization, triggering compassion fatigue, burnout, all of the negative consequences that we can have from this. I don't have time to go into all of this, I'm sorry. These are what fight, flight, and freeze look like. And I have in here, what do we do about fight, flight, and treatments in the course. And then I talk about responding rather than reacting. Reacting is an emotional thing. Responding is a thoughtful thing. It is a, there's a lot of people, text there. When do you consider it? All the time. All the time. Pre-trial diversion, meeting and treatment teams, looking at evidence of defendants' behavior, watching their behavior. When you're considering mitigation, even if they've been found guilty, you need to think about that. Deciding upon a sentence all the time. That's trauma-centric case processing. There are a lot of resources here. There are different things, every subject. This is a self-help book from Lisa Magowitz that she developed based on sentence safety, which is really terrific. There's BBT, there's cognitive processing therapy, prolonged exposure. That is, if you want to do EMDR on yourself, only use that book. That is a self-help book that she developed, Francis Shapiro developed. We do know some things about trauma-informed courts, and there are references that I give to you. There's self-help things you can do with PTSD. This PTSD coach works almost as well as psychotherapy. Almost as well. If people do it. If people do it. And that's how you can contact me. I'm Meyer, PhD at gmail.com. I want to